first one, obviously, is still the recognition of the transition that we're going through as an ICB. And what I've tried to do is just summarise what happened in the transition committee, particularly around the new member with Joe Medhurst representing the clinical representation at the committee, looking at check and challenge with regards to recruitment and particularly EDI, and then obviously the launch of our exec structure, a consultation, and the future launch of voluntary redundancy for the organisation as a whole. So I say, as always, I'm not going to read the paper out loud, but they're the main things in that section. The second big area, and a revised timetable in there as well, which people can see, is that we are working towards a full organisational consultation document in March. And that in itself brings challenges, both in getting the work done by March, but also the finances, and people will know very clearly in the public domain that NHS has secured resources from Treasury for us to do work on this in 25-26. Second big thing then is preparing for winter, and I think it's just important just to present in a really simple way the work, 5 areas of work we've done to prepare for winter. And you can see that in the report in terms of control centre, in terms of management of demand, etc. And you can see all of that. But what I really wanted to pull out was the importance of vaccination. And we are seeing already worrying signs. We're seeing worrying signs, certainly, if you look at what happened in Australia, and you see what's happening now with regards to flu and COVID. And therefore, we have had a really good start in BNSSG, but in this public forum, I think it's really important to call out that one of the best weapons we have in winter is vaccination, and we have to make sure that we can get a way of ensuring that our population and our staff are well vaccinated for winter. And I mean, it's certainly, even the demands this week, Maria, in the acute world, we saw considerable increase in people coming through the front door, and therefore really important with regards to vaccination. And then the third part of my report isn't really one of 3, because I put 3 things in the last bit, but I think it was really important to reflect on there's an awful lot of pressure, an awful lot of stress in our system at the moment for our employees, for our partners. But I wanted to call out success, because we don't always call out success. And I put 3 things in the report which I think we should be really proud of as a system. The first one, the HSJ Awards last week, a magnificent piece of work which is across Sirona, local authorities, the judiciary system, looking at really driving good outcomes for children, young people, who otherwise were in real danger of becoming part of the criminal justice system. And really fascinating piece of work. And that was nationally recognised last week at the HSJ Awards as a highly commended, which technically is the runner-up, but we don't call it a runner-up anymore, highly commended. The second thing is the amount of work we're doing in Workwell. We are leading the way across the country in Workwell, and a lot of stuff that Joe and our team have done to make sure we can connect that productivity, working well, and getting people out of that trap of sickness and unwellness. So a massive piece of work in there. I look forward to future years of that work. And then the third is the work that we've been doing with regards to the local maternity and neonatal system with Black Maternity Matters, Black Mothers. And again, some really outstanding work in that space, and it's being recognised again by the Health Race Observatory as really outstanding work. So I'm just conscious that often the reports are how hard things are, and the challenges we've got. But we do some very, very impressive stuff, and I just wanted to bring that to the chief executive report as well. Okay? And I would suggest that we should continue to do that at every report and just have a celebrating success as we head through what will be a very turbulent winter and then on to the next year. So happy to take thoughts, comments and questions, Chair.
Thanks very much, Shane. Steve?
It's just, thanks, Shane. Great report. On the vaccinations, which you're absolutely right, is our best defence, and but it's worth us noting that there has been confusion in the general public.
Okay.
Flu vaccination, absolutely, but the one that's caused the biggest issue is vaccination around COVID, which is very specifically targeted to vulnerable groups and over 75s. That has caused quite a lot of issues in pharmacies and in general practice, I think, because the general public assumed that it was similar to last year. And I just think we
Okay.
need to understand and recognise that what we're seeing, certainly in working populations, is spikes in COVID as opposed to general flu. That's what we're seeing, and some of that is leading into hospital admission as well. So I think we just need to understand that, you know, the general public got a bit confused. That put more pressure into the system in terms of explaining why they could only have one flu jab, not the COVID plus flu jab.
So if I could, I'll ask Jen to have a look at that, because obviously we've got a big comms programme with regards to vaccination. If there are confusing messages, we could test that out and see what else we might need to do to try to clarify that message. Steve?
Thank you.
Maybe I could just pick up a point on that as well, and maybe it's for review of how this winter goes nationally as well as locally around COVID, because this year staff who aren't in high-risk groups are not eligible for the COVID vaccine, but on risk registers, COVID and staff is a high risk, which I never quite got my head around. So there's a national decision that actually staff don't need the vaccination if they don't fit into the groups, but our risk registers will tell us it's a high risk if staff. So I'm guessing I don't know if we are where we are, but there will be something to look at how this winter has gone, because those two things are both correct.
Correct. And I suppose what we will do, because we always do, is review the system. I think that's and I would look to Joe as CMO. There's probably quite a large CMO conversation that we had at a national level to see whether that set of decisions has proven to be right. Yeah.
Jaya,
To take that one step further then, if all our staff are on sort of in the scope of the risk that the COVID, then are we able to track the number of people who are privately getting their COVID vaccinations and how that feeds into our system? Is there any way of knowing?
No. But to the best of my knowledge, not. I'd ask Joe for that.
First, we'd have to get consent, Jaya. So it's your personal medical history. So you'd have to have a consent process to it. So it would not be something we'd be able to track on the phone.
That's a shame, because that would be a good indicator, wouldn't it? Thanks.
so just to check then, Joe, is it too late to raise the issue nationally this year that we're seeing increase with staff with COVID, or is this the big risk and yet we're not offering
I can
it?
definitely explore it. I mean, the risk at the moment is flu.
Okay.
It's flu that's rattling through our communities, it's rattling through the staff levels, and I'm assuming there's been, and I don't know, so I'd have to research it, but with some of the COVID stuff, that risk balance between the impact and the relative limitations, and in fact there might be a bit of herd immunity from previous COVID, limits it. Flu, do you remember it changes its antigenic nature every year, so you see every year you see a large impact of it, and we are seeing that at the moment. It's flu that's the issue, isn't it, Maria, in work, and Joe in our workforce at the moment.
Can I check if we're doing a comms message internally and externally?
Yeah, absolutely.
And so the internal one, the availability for people to get vaccinated, because I know in the hospitals the trolleys that go around the wards. What are we doing with ICB staff?
There's been loads of people in the ICB offices. We've got a television screen flashing the fact that it's important up, emails, drop-ins. It's comprehensive.
But it's always surprised me as chair of a trust how few people, and I suspect it's gone up, but how few people working in a medical profession don't get vaccinated, even though the availability is there. I don't know what the percentage is like at the moment in UHBW and NDT, Maria.
It's pretty good. It's in the 50s, which is a big improvement.
Yeah.
Obviously, we didn't do COVID this year, which, you know, again, you wonder if there is some sort of, you know, build-up and synergy that goes alongside. I suppose the efficacy of the vaccine as well is something that people are questioning because it changes so quickly, and I know that has been an issue clinically.
Effective, so that puts people off. You can get side effects related to it. There is there's lots of research. It's multifactorial, but that efficacy element and its conversion to.
But you would think, wouldn't you, if we can't convince our staff to get vaccinated, even with incentives, it's a hard message externally as well. That said, it's got to be a benefit. We've got to keep trying, haven't we? But okay.
Thanks, Jeff. Any other comments or questions for Shane on his report? Steve?
I just want to acknowledge the success stories. because it's really easy to focus on some of the areas where we have challenges, but those successes, particularly the first two, are real collaborations as well between different parts of the public sector, the health system and the voluntary sector, and it's very much a precursor for where we want to go going forward. So I just wanted to acknowledge those.
Thank you.
Well said, and good that they're going to feature as part of
Regular feature now.
Great. Okay, we'll move on to the items for assurance and approval. First one is, and we are a little ahead of time, it's the update on integrated neighbourhood working, which is a really good paper to have. Now, Debs is the executive sponsor and obviously isn't here. Seb isn't here.
Kate Lavington just walked past.
Yes, Kate. Sorry?
I was just wondering if maybe
Do you want
the guests here?
MCJD.
We can go. We do cardiovascular first.
Yeah, no, that's sorry. I wasn't. Telepathy wasn't quite working. I didn't know what you were saying. Okay, so what we'll do is we'll hold fire on 6.1 integrated neighbourhood working, and we'll go to 6.2 cardiovascular disease. Joe, take us through. This was a really important, interesting read. So, introduce us to your colleagues and.
So, Coach, would you like to take centre stage while I do the preamble? So I'm very proud to present this paper to you because I think it's a really important paper about how we might look at population health and the insights around population health, particularly as we go in and if you look at the guidelines in the strategic commissioning framework. I cannot take any credit for this work. This is this group of people here and a wider group coordinated by Ruth, who works in the health improvement team under my directorate. She will go through the history of it, but we picked this equality objective. And I remember when we did it abroad, it's a bit like, oh, it's a bit narrow, Joe. There was a bit of a squinty eye, wasn't there? It's the right thing to pick, but we did it based on data. And then a load of work happened, and the group here will describe what that work looked like. But taking something very narrow and very specific based on population health for a narrow cohort, we've gone through what this means for people, what it means for families, what it means for our communities, and taken it all the way back round into broader, genericized commissioning intentions, which might alter wider commissioning. And I think that's the right way. You dive on something specific. You exhibit, I hope, cultural humility, which we talked about at our last meeting, and you hear people's voices, you hear their experiences, and then you take that and go back round into, well, how does that change a future state we might be in? So I think this paper's got a number of different parallels that we might learn from, but I will stop talking. I'm going to let Ruth introduce the team, the work that's been done. It's going to be 15 minutes for people just to sort of explain what happened, and probably 15 minutes for Q&A, which I will facilitate.
Thank you, Joe. And just before you, just in terms of the recommendations for the board, it is about us discussing what the recommendations mean for future commissioning, and it is about asking us what we're going to do next with the recommendations. So just to be clear what our role is in this today. So,
over to you, Ruth.
Okay, thank you. Shall I use this? Can you hear me okay? So we'll each introduce ourselves individually, and we're each going to say a little bit, and then we'll open up for discussion on those points that Alison made. So yes, I'm part of the ICB Health Inequalities and Prevention team, BNSSG, and some of you remember I came to Somerset Hall in Portishead last November, where we had a health inequalities seminar, and there we talked about setting 4 equality objectives for the ICB. So that's under the public sector equality duty. All public bodies have to have them. And we set a cardiovascular disease equality objective, and that is to improve the treatment of high blood pressure in our Black African and Black Caribbean populations by 2029, and to reduce the gap in treatment between our Black African and Black Caribbean populations and our white population. And we discussed at the time that's because local data outlined that there's significant inequalities in treatment for high blood pressure in Black African and Black Caribbean populations. So this means, we'll talk about it a bit more, it's clear in the paper that it's not just about diagnosing people who we don't know have hypertension, it's about people we know are diagnosed, we're still not optimising their treatment in general practice. So we also set the objective because we know hypertension is one of the biggest risk factors for stroke, and cardiovascular disease in general, heart attacks, related conditions like vascular dementia, and we know black populations are disproportionately affected by hypertension, strokes, and other conditions. So what have we done? So earlier in the year we decided to set up a system working group, which I think happens ever so often, And for 6 months, we explored how can we actually achieve this objective by 2029, because it is very ambitious. So in March, I worked to create a group of 12 of us. So obviously there's 4 of us here today, with a focus on people with lived experience and VCSE sector experience to ground this data and the evidence in local realities of what is actually happening on the ground alongside healthcare professionals. So I guess the group we brought together is pretty amazing. It's collectively decades of personal and professional experience of cardiovascular disease prevention, hypertension treatment, knowledge, working with black communities. So I think what was really interesting about this work was the group agreed that we wouldn't be quorate unless there was 2 VCSE reps, 1 general practice rep, and a third of the group were present with black African and black Caribbean heritage, which was really important. And so between April and October this year, we've met 6 times for 2 hours, and we've had like a sort of safe space where we've been able to explore, debate the issue, try and work out what can we do. So we reviewed the data, we reviewed the research evidence, we questioned it. Each person contributed to kind of enhance that with their personal, professional, community experience. So it's quite a thorough process, and what came out of it is that quite clear and simple report that was co-produced that you've seen in the papers, and a set of recommendations that we are recommending to commission against 10 outcomes that are on page 12. And we think we really need to commission against them and to have a chance of achieving the objective by 2029. And we're thinking these could inform neighbourhood planning and other pieces of work that are happening next year. And I think there's something I feel really important about the way we've done this work, that it's like there's a lot of good learning about how the ICB can be involving public contributors and VCSE more in strategic commissioning, in commissioning for outcomes. So that's my take on this 6 months worth of work. So I'll hand over to Cheryl, Kane, Davinder, each going to sort of give your reflections.
Before I say something, I'm
Yeah.
going to do a quick handshake of everybody. I want you to know that I am the person in the data. The one you're talking about when you make these decisions. Not numbers, not figures, real people. Real people, real lives. That's me. I matter. I'm important. And when you're making your decisions, commissioning your services, remember me. Got 2 minutes left now. Okay. My name is Cheryl Simpson. I've been a public contributor. I'm a retired child protection social worker who currently fosters for Bristol City Council. I volunteered to work with the CBD group to tackle the inequalities in hypertension in the treatment of Black African and Caribbean patients. I wanted to contribute and make a difference. We work hard to make objectives that we feel are achievable and will make a difference and save lives. The Black Afro-Caribbean and Caribbean community feels the consequences of ill health and deaths caused by diagnosed and undiagnosed hypertension. This is our lived reality. It's our parents, partners, children, extended family members and friends who are dying and becoming disabled because of hypertension and the other related comorbidities. It's having a devastating effect on family relationships, friendships, finances and life opportunities. The data speaks for itself. You've all read it and understood it. This does not need to continue to happen. I want better for my already demarginalised community. By changing the ways we commission services, making them more specific to the needs of the communities they serve, by implementing the 10 outcomes which address these issues, I believe things can improve over the next 4 years. For this to happen, the people in this room who have the power to make decisions must take a pivotal role to augment change. I'm throwing down the gauntlet and asking you, are you willing to do what needs to be done? Are you willing to make a difference? The future health of my children, grandchildren, and all those other family members who live in the Black Afro-Caribbean community depends on it. I leave it in your hands.
I'm just going to put out 3 things that I'm going to talk around, okay, in about 3 minutes. 3 minutes? Yeah. Oh, if I just put that. You know what to say something? They're all from our community groups' poems, by the way, not just things I've made up. I'll talk as loud as I can. Right, so my name's Kay, I'm from the Voluntary and Community Sector, and Kay, just from the Voluntary and Community Sector, and I'm representing the VCC Alliance today. Now, I'm also part of a study, and many members in our community group are, which is at Bristol University. It's called the Under Stress Study, because black women are still 3 times as likely to get a stroke. That's local stats as well as some stats from America as well. The Race and Health Observatory, I've also done some lot of research and tabulated a lot of things and found that we're more likely to get heart failure as well, sometimes on average 9 years younger. So these were reasons why I got involved after watching both my grandparents die, one in their 60s, something that's preventable. I'm going to talk now about why, so I'm quite emotional because as I'm speaking here, my closest family member is in hospital with, they call it AF, but it's still cardiovascular disease. So for me today it's very important for the future, as Cheryl said, of our children. Now, why we fall through the treatment gap, it's not because we don't understand. I think that's an excuse. People say they lack understanding. It's not. I was just looking just yesterday, preparing for another talk, and I was looking at how many black people are actually in medicine, and also in terms of how many of us are also represented as nurses. The Nurse and Midwifery Council showed that we're up more than ever in terms of diversity in the nursing profession. That isn't the problem. There's 32.8% it was saying. And then also, in terms of black people in medicine, that's also up as well. So it's something, this is from NHS England, 46.8% as of March 2024. We have enough people who are black in and Asian to build trust. That isn't a problem. We understand. Most of us know somebody in healthcare. I myself have worked in the health sector before. But what I'm saying is that there is a disparity. Now, why we fall through the treatment gap, I'll be as quick as I can, is because sometimes there are hundreds of different types of people, but people bring their past experiences for the health sector into how they take up services. I brought with me a defibrillator from someone's house, an old, unused, put down one. That represents people who've had bad past experiences and don't like to feel judged. So what they do, they prefer to watch and wait, because sometimes it gets too late. When they've had a TIA or a cardiac arrest, they then take action. But by then it's too late. So that's one group of people who need more proactive follow-up, not just a text message, because they avoid unwelcoming environments. Then we have the people who, they may be on borderline, they may have had elevated or stage 1 hypertension, it's 130 or 81 or something like that, and then they believe I can control this. They increase their physical activity, they increase their lifestyles, as I put on the poster, and they miss the opportunity for early treatment, blood pressure, because they think we're used to being strong, we're used to being told that we have to be in control, we're used to normalizing it, we're used to being second best. I'm used to putting everyone in front of me in my workplace. I'm used to putting everyone in front of me in my home place, because that's the way black women are, but we've got highest risk. The group I'm going to talk about now is the ones who start the treatment, and that's represented in the blood pressure machine that's switched off. No. Yeah, final point is the final point. Yeah, it's okay, you don't need to monitor me, I'm monitoring. Yes, I know, I'm monitoring it. I am, trust me on that one. Yeah, so it's the ones that start the treatment, as I was saying, but they don't continue. Because they may have started medication maybe 3 years before, but what they haven't done is realize they may have put on weight or had some extra stress in their lives or had other things go, to make their blood pressure average, or they don't use the monitor consistently. They don't take it average, they don't do it 3 times a day, they do it as and when, because they are people who feel that they're on top of the treatment, and then also they don't even think the cuff size may have changed. So it's basic things like that. So, and slippage as well, in terms of their taking up their appointments. So thank you very much all, and that's just to give you some aspect, I've got more, of why people are falling through the treatment gap.
Thank you.
might just have to hold it. So, hello, thank you very much for giving me the opportunity to talk to you today. My name is Dabinder Rashid Fadal. For those who don't know me, I'm a cardiac physiologist by background and worked in the Bristol Heart Institute for 30 years before I set up Acure Health. This is a fantastic opportunity and a privilege to support Ruth and the ICB colleagues on this working group and to bring my experience to the table. The graph on page 5 within your papers clearly shows that those that have had blood pressure recorded within the GP practice from this community had the worst level of treated to target across all of BNSSG. So what does this mean? If they have been able to access the service and have that blood pressure recorded, they are still not being treated to target, leaving this high-risk group open to strokes and other cardiovascular events. CVD is still the leading cause of death for all ethnicities, and if you are a woman, you're twice as likely to die of a CVD event than you are of breast cancer. The working group debated, discussed, and we pondered over many issues as to why this might be the case. So in order to support this community effectively, we have come up with some recommendations, and we have agreed as a group that they are achievable. We are living in times where health inequality is widening, and communities like this are still being failed. Last year, Acure Health was commissioned to deliver a cardiovascular disease prevention programme across BNSSG. This was funded by NHS England. It was a one-year programme, and we delivered a community-based health check model. Our approach was taking services to where people feel safe, known, and welcome. We delivered a phenomenal 93 health events in 8.5 months. And this included a case find for all and targeted work for underserved communities such as the homeless, drug substance abuse, etc. For this particular group, we worked within churches, and for example, we targeted the Black Men from Mental Health group, with a subgroup which faces many barriers to health. We worked with a local barber in the inner city east locality who runs a voluntary get-together twice a month to support his own community. So we worked with him to be able to reach that group. And he has since become one of our community champions and is a volunteer that holds blood pressure monitor within his shop and makes it accessible for local people with cardiovascular disease. Our findings from this group particularly was that 43% of those that had their blood pressure measured had hypertension. Some were known hypertensives, but required a review for their treatment, exactly what the data is showing you on page 5. We also found that underserved communities as a whole had CVD factors such as hypertension and high cholesterol present in the under 40s. The current age for NHS health checks is 45. So for many of these groups, by the time they reach 50, they have had a CVD event. This is well within the working age, thus having a direct impact on economic growth and, of course, their quality of life. Community-based prevention only works when it's built on trust, familiarity, and genuine partnership. Many thanks to the ICB for the opportunity to contribute to a community voice that we have formed together within these recommendations that we have given you within the paper. Thank you very much.
I want to say just finally is that it's really important that I know you've got the 10 recommendations, but there's something about the age, and you said about the 40. I just want to emphasize that. There is a program in London, in Lewisham, where they found 25-year-olds prevalent with hypertension. And, Diversity, Health and Wellbeing, CIC, they're called. And they analyze all the primary care data. And what I will say is that they're advocating younger ages, particularly for our age group. The 40 mark is not relevant in that way.
Thank you all. Fantastic presentation. This was also presented at the Long-Term Conditions ODG, which Cheryl presented. Again, had a very strong impact on the group, and the group reviewed it from that sort of medical nursing lens and really recommended and supported the recommendations in the paper. So we've now got 15 minutes for some questions and answers. So I'll just open it up to the floor, Alison.
Yeah, that's great. Could you just thank you for coming today. Thank you for the challenge. Actually, that's quite helpful, and I think we've all heard that. So I think that's quite important in terms of the recommendations about what we do next. It's about us doing something next, isn't it? So thank you for your time, thank you for your energy, and we will open up. Do you want me to take us through this bit, Jo?
It's up to you, Alison.
Yeah, that's fine.
You can?
Yeah, that's fine. Yeah. So, colleagues, Jeff.
So first off, big thank you. I think most of us met at the Race and Equity group a couple of weeks ago, and it's a powerful message. But also big thanks to Jo and to our 3 directors of public health, who I think have collectively started to look at the data in a different way. And when we amass all of our data around cardiovascular disease, it doesn't give us a true picture. It gives us a collective. And what we started to do, and I think this was a decision of this board to establish the Strategic Health Inequalities Committee, which is starting to look at things like this in a bit more detail. So we are now starting to see specific things, like Jo has said, cardiovascular disease, and when you cut the data by race or by age, it gives you a very, very different picture. And I think that is going to be absolutely critical for us as a strategic commissioning body going forward. So when we as a board are making decisions about where we put finance to support healthcare, then actually this is critical to the way we make our decisions, because otherwise we make our decisions based on what is predominantly a privileged background of a white male or female. And that is, we think we're doing the right thing. I always think I'm doing the right thing, why wouldn't I? But the reality is, we look at it in a different way. So, Jo, big thank you to the work that you're coordinating that committee, but also big thank you to our contributors, because it's just so helpful, and particularly to yourself, Ruth, by bringing everything together.
Thanks, Jo. Well said. Jaya, over to you next.
Yeah, once again, thank you. I was tearing up as well, not because the report was about me, although my mum, strokes, dementia, my dad, heart disease, plenty of stents, really in a bad way. So I resonate, because I've been somewhere where you've been. I wonder what the key takeaway in terms of messaging is, because one of the recommendations is about messaging, and as point taken, it's a lot younger that we're looking at, not just the older generations that are kicking in with this sort of condition. What can we do about messaging? What's the key thing that you think we need to be getting out there?
I think there's not just one thing that will fix this, because there's many barriers for this community, as for many other underserved communities as well. But it is predominantly around trust and ensuring that at every point that there is clear messaging, and specifically for this community, whether it's the information that we're providing, whether it's the interaction that needs to be in a timely way to ensure that people have the opportunity to ask questions, whether they need to be able to access services as in groups or but in community spaces. You know, is that element of trust, is that element of that specific for this group that is currently failing, like having one service that fits all?
Yeah. If I pick that up, Jo, if I may, one of the things you've heard me talk about is the silver bullet-itis that we are a bit at risk of at the moment. What's the one thing and the one intervention?
Yes, I appreciate. It's more about what's the one key linchpin thing that we need to do first, and then we work it on out.
I think, for me, what I was trying to show here is, and I get back, see, the data shows one thing, but actually you get beneath the surface of the data, which you can only do by talking to real people with real stories and accepting they're from different places in the world with different backgrounds and different legacies and histories. And that then allows you, if you let yourself be absorbed into that sort of, that really divergent noise, from that you can get some things that you can then add on. So it's allowing ourselves to open up and hear, and then take what emerges from there, because not one person can tell you the one thing. We've got to do the work, and it's messy work. It's a messy, noisy bit of work, but then you get to some informed decisions.
Step by step.
And in strategic commissioning, I think that is what it's asking us to do. So this felt a really important time for the board to see a different way, maybe, of doing the work. So that's what I was, again, it's, I know what you're trying to say, but I just you've let me into
no, it's fair.
Strengthen a point. Thank you.
Lots of people want to come in. Thank you, Jay, for raising that, and Joe for coming in. Steve, over to you.
Thank you, and thank you very much for your heartfelt and powerful stories. Your voices are really, really important, and they've been heard. I think the paper is also very well written and simple to engage with, which is really important. Sometimes we get very dense papers, and that's hard work. I think the really important thing here is that this matters because our job is about commissioning the right services at the right time to engage with all people and not just some people. But we also recognise that there are barriers for some members of our community, so we have to work harder to engage with those communities. And we can't do that on our own, we have to do that in partnership with those communities, number one. Number two is listen to the communities to understand the best ways of influencing and educating and thinking about what's best in those communities. Don't assume. So your points, I think, are really well made, so thank you for that. This is one of those things which is about prevention is way better than intervention. So we have to get that message out to communities to be able to engage in an effective way, because it's about the prevention bit. So they may not quite understand because there's no burning platform at that point. The only way we can do that is by working in partnership with you. So thank you. I think you've reinforced our future job in terms of commissioning, but you've also made us think about how we do that. And it's not as simple as just going through an exercise to commission a service. We need to understand what's the purpose of the service, what's the best way of engaging with the people who need access to that service. And that's sometimes difficult. The final point, and you made it very well, you need to do this at a much younger age. 40, 50, 60 is too late. We need to be in right at the beginning. So I think, again, a point well made. So thank you. Thank you very much.
Thank you, Steve. Kevin, over to you.
Jeff, thank you. Hey, see, just to echo, I think the report was really clear. I'm going to do the boring report bit first, the academic bit. I think that was really important because it's a step on from reports that I've seen historically about this, which is actually how this informs commissioning. And I think that's the key thing, that link, kind of that hook into the system. There's something in me which is I feel really frustrated on your behalf as individuals and as representatives of communities who often see worse health outcomes. I'll tell you for why. Because I don't think I've read a report in the last 20 years that doesn't say there's a lack of trust. I don't think I've read a report that says we don't communicate well enough. I don't think I've ever read a report that says relationships are so strong we don't have to do anything. And I think I just wanted to reflect that back, that hearing it from the three of you today as representatives of this piece of work, but as individuals who feel that. I think that's really important for us to hear here today. The paper is really good, but your challenge is really important. What is it we have to do to actually move that dial forward so that there is trust, and how do we have a hyper focus on developing trust in the same way that we do about developing dentistry pathways and pathways for other health interventions. Trust is kind of the biggest asset we have in our communities, that there's an absolute focus on how we build that trust, and we know it's important, but where are the groups looking at how we do that? And so hearing your stories today is really important. It just reflects and magnifies that whilst everybody in this room is absolutely doing their best, we need to focus on those relationship sides of it that don't always get the space they need to be discussed. So thank you. Yeah.
You mentioned trust. Now, I don't want to, Cheryl and I were talking before, we don't want to over-empathise that Black Caribbean community, because where I come from in Jamaica, we trust our doctors and we do trust clinicians. We want to have clinicians involved because then you've got that monitoring and that rigour. Okay, I'm from the community sector, and what I will say is about the assertive messaging, plus people in the NHS who are Black, Caribbean, Asian, can build that trust. There are enough of them. But we need to look at how we treat our staff. That's one of the things that will build the trust. So can I just say, away from, trust is just a very small part of it. There are bigger issues for people who, I trust the service, I do. But it's balancing it against all the other pressures when you go to have the surgery, the time of the surgery, you're juggling school runs, 3 jobs, many of us because of the pay gap, 3 jobs. Also juggling things such as immigration, some people, whether or not they're going to go forward, they also have to juggle things such as the school. There's a lot of pressures. So trust is a small part of it.
Did you want to come back in?
Can I just add one thing on that? For 30 years I was at the BRI and I saw the treatment side of things. So when people presented for intervention or sadly came in through A&E as an emergency. Now, so for a long time we were aware that treatment options were available for everybody, but we were also aware of the people that got to that front door. Having worked within the community sector now for 10 years, I can see, and I obviously knew the health inequalities within those 30 years, but for 40 years now, I've seen health inequalities, and I have also seen that they haven't got better. Having worked on that 1-year programme, working with underserved communities from everywhere, and yesterday, again, I was with the Gypsy Roma travelling community, delivering CPR training for them. Now, these groups are underserved. There's no question about that, they're underserved. These groups have still got worse outcomes in terms of health, and they're not making it to the BHI in terms of primary angioplasty or anywhere else. Sadly, they're ending up in the morgue or disabled with a stroke. That it has a significant cost, not only to those families and to things, but also to the economics of the country. This is within working age. This is what's happening. And actually, if they make it to retirement, they've got a few years left. I mean, I can't really, let you see everything that I've seen within 40 years, but it's huge.
Thank you. We've got more people wanting to know. I just want to pick up Kevin's point and others. It's what we do. I also think it's screaming out at how we do it, because are we using people who know why something won't work? If we say, we're going to create this pathway and it's really shiny, it's really nice, and that's it. But actually, we need to listen to people who are going to be using it and tell us what will, we've used the word derail, what will stop it working. So I guess for me what's coming out is it's not just what do we need to do, how do we make sure we use all voices to tell us how the best way to do it for it to be as successful as possible. And that feels like a big chunk of the pie that's crucial. Because we could have the best pathway or whatever in the world, but it may not produce the outcomes for the people that are best because it doesn't fit. So it just came as really important. John, over to you.
Thanks, Alison. I'll be brief because Steve and Kevin have largely said what I wanted to say, but I just wanted to say thank you. And the slide, the lack of trust and health literacy slide really resonated with me. I don't have this particular condition, but I've had AF and I managed something else, so hopefully there are kind of good outcomes for your family member. But kind of stating the obvious, it's kind of facilitating and supporting people to develop good habits around medication, taking the medication that's been prescribed, thinking about your diet, thinking about exercise, attending the appointments, taking the blood pressure readings when you're asked to, and having the blood tests and so on. It all makes a huge difference. So the easier we can make that, the better. So this really resonated with me. It's kind of now how we bring the 10 points to life. Thank you.
Yeah, thanks, John. Great. Shane and then Steve.
Yeah, thank you. First of all, thank you for the paper, thank you for your presentation, and thank you for what you've done. for me, reflecting on the 10, I'm going to use an analogy that Joe used yesterday in a meeting that just really struck me. We tend to commission a thing, okay, and that thing is a pathway or a service. And there's an analogy Joe used in a completely different situation, which was, that's the fish, we've got to think about the water. Okay? So actually, the thing we commission is the product, but that doesn't work unless we get the whole of the everything else that contributes to the success right. And I think the 10 actions, 10 recommendations, can help us commission the whole thing rather than just commission the pathway. Because we can have the best pathway in the world, but if there's not the trust or not access or not, then the pathway just won't get used. So for me, the 10 actions absolutely, to go back to your answer to the question you had at the beginning, absolutely provide the basis for us to think about how we commission services moving forward. Not just CBD, but how we commission services moving forward. And as you know, when as we're setting up a new organisation, I keep talking about the first part of the commissioning cycle is to deeply understand the population, make sense of that, and then make recommendations to move forward. That's what this paper is doing. It's showing us how we can deeply understand the population we have to serve and then make recommendations. Now, delivery requires us to live to those 10 recommendations rather than I just want to buy a pathway. So you showed it to me a couple of weeks ago, Joe, particularly the slide on trust and literacy, and it just caught my attention. This is strategic commissioning. This is what we've got to do. And you have taken it inch wide, but mile deep in really understanding. So there's something, firstly, profound for commissioning, something really profound about how we're going to deal with this with CBD, and we've got to do that. But this is a much bigger issue that actually this paper just opens up what our job is as a commission. So brilliant is the way of describing it.
So at the end, I've got some specific asks.
Good. I thought you might
I was
have
hoping.
Yes, okay. Thank you, Shane. Steve and then Joe.
But did you want to come back on that point specifically?
I've got a question about how we make it work, so yeah, I'll go last.
Okay. I also, similar to Joe, I'm sitting there and I'm it's been quite uncomfortable for me because I'm sitting there thinking about my dad who I lost in 2018, who probably for the last 8-10 years of his life was really affected by vascular dementia, affected his speech, his movement, etc. And I wish I knew what I knew now, what I knew then. I knew then what I know now in terms of trying to support him to live healthier for longer after he retired. And I'm also in that category of black men that tends not to go to the doctor until there's something wrong, you know, and it's reminded me that I need to stop ignoring those text messages that I keep getting. so
Nothing else, we've achieved something, haven't we, Steve?
Yeah. And I'm someone that's in the system and knows a lot, and yet those biases I still have culturally about you go to the doctor when you're sick are still there for me. But sorry, the question I wanted to ask you all was, taking the service to where people are, what difference do you feel that's made to the response you've had, and then the ability for those people to then adhere to some support in treatment?
So the programme we ran as a Cure Health was out in the community, and we went everywhere. We went to shopping malls, churches, places of worship, and community settings, over 55s groups, food clubs, you name it, we were there. And we ramped it up. We got through 93 events in 8.5 months. We had fantastic engagement because we worked with those community groups to say, what is it you need to engage with us? Sometimes they said, come on a Sunday morning after worship. Sometimes they said, can you come in an evening? We said, okay, you know, because those are all barriers for why they cannot access care. So we made it as simple as possible. We took people along that spoke the language, that knew culturally what they needed to kind of do in order for that engagement to happen, whether it was gender specific, whether it was, you know, specific languages, whether it was, you know, we had to respect that community and that community's wishes to ensure that we built that level of trust. The interesting thing is, once you build that trust with a community, that takes some time, you're in. you know, the GRT community have been talking to me non-stop saying, come back, do a women's health programme, come back, do CPR training. And, you know, everybody says, oh, they're a really hard community to reach. They're not. They're underserved. And, you know, so the engagement definitely was there. In terms of did people care about their health? Yes, everybody cares about their health. You know, so they did come out. As soon as they knew we were coming, we had a large number of people. We checked over 1,500 people within that 1-year programme. And that was for blood pressure, diabetes and cholesterol.
Thank you. I want to pass on just a couple more questions before we get back to you, Joe, if that's all right. Joe, and then Jake. Thank you.
Yeah, thank you. I'm blown away by the work that you've done. It's amazing. And I'm 4 weeks into my job, so I don't know Bristol very well, so forgive me if I don't know all the answers, but all the questions. But I met with my community specialty team on Friday for Serona, who say we've got community health advocates, thinking about your point about clinicians, who are working with the voluntary sector, and we've recruited people from different global majority groups speaking different languages. And my question really is A, I just want to say I'm blown away, but B, when we go back to strategic commissioning and we want to commission for outcomes, the reality is when we're in the world that we currently live in, is people are asking for throughput, productivity and outcomes. And so my question is, how do we get this right so that we don't, when the going gets tough, veer away from investing in the VCSE or the health community clinicians or whatever it is we need to be able to make this really work at scale and in the right places, because it doesn't give us the data. It's just working out what we need together to make sure, because we've done loads of work in a previous world on productivity, where the ways that we measure stuff at the moment, they don't help us deliver the outcomes that we're trying to deliver. So I'm interested to see how we can support that, because I've got a bit of a data head, but I've also got a passion for getting this right. So I'm with you. It's just a question for us as a board.
Can I just make one point about what Shane said about the kind of pond? And obviously this is quite a small, specific piece of work that we did. The two things I would say that helped and the things that didn't. One was the VCSE Alliance and the ability to quickly pull on 4 people who have decades of experience and knowledge of the issue was a game changer.
Yeah.
I could do that in a 2-month period.
Yeah.
So that was one thing. The thing that was harder was the infrastructure around public contributor involvement was a little bit blurry, had to work that out. I was going out to community events just to meet people. I met Cheryl at an event. So that's something that we could improve in all providers and ICB. And I think this did take a lot of time. I probably had more time than I might have because of all the NHS changes. So it's sort of what things can we commit this level of deep dive into, given we're going to have less people. It's in the ICB specifically, it's challenging. I just wanted to raise that through here.
Thank you. Let's move to Jake.
Thank you. Really good to hear. For me, from a theoretical basis, I think we all know about these sort of embedded structural inequalities that exist. But it's the data, it's the information, it's the stories and the connections you make with people that then helps that to change and drive that inertia for people to behave differently. And although it's not described in one of your 10 outcomes, I think just these types of conversations are really powerful. And I think that is for us to continue having those. So as a group of sort of senior GPs, there are not many that I hold, which is the General Practice Collaborative Board. There are not that many people with black faces. It's a largely white group, and I would like to take these stories and this data back to that group and say this isn't okay, and we need to do something differently and be part of change. So thank you for coming.
Thank you. Joe, I think over to you to summarise and next steps.
Jake, you have led me on beautifully into the so what question, because this group here have committed a lot of time and a lot of energy and put a lot of vulnerability into this. So I think it behoves us to do something with the broader recommendations, particularly about culture and literacy, which I think are applicable for many areas of healthcare commissioning we have. So I would like to ask everybody that this paper is referenced in our final joint forward plan. I'd like to see it referenced in all the neighbourhood plans as a reference document that people have looked at and responded to. I'd like it seen whatever comes out of our strategic commissioning framework as a bold commitment. I think, Jake, I was thinking, so I've already had one of the deep end GP say, I know you're doing work, can I see this paper? So I've shared it with her, but I think taking it through the One Care infrastructure, brilliant. Richard, is there somewhere regionally you'd like this presented? Might be the regional inequalities group. I've already said I'll share it with the National Public Health Director. Joe, what about Serona? Where can it go? Steve, what in the voluntary sector? You probably know all of this and you're just going, told you so. But if I can ask your individual thing, what can I use it for? But I did have a few specific things which are all our strategic planning documents. So this is referenced in it and we respond to it where we can to alter how we commission care. And then I think that will allow us to make a change and to make this work meaningful in the way we commission services going forward. I think that's probably where I'd land, and that's what I'd ask the board to agree with, if that's okay.
So there's two levels, isn't there?
Yeah.
There's the very specific issue where we need to see some improvement or outcomes in this group. So that's and I guess as a board, what should we see and when, because we don't just want this to disappear now.
So from that's from the long-term conditions operational delivery group. It was taken in there. The message Cheryl very clearly did this message, and we're taking actions in how we do our cardiovascular plans, which is still the key overriding priority for everybody in our population. But that's been taken through that route, which is under the community age. So.
Yeah, and then we will see the outputs.
Yeah, but at board level, this is the more strategic.
Yeah, so the second bit obviously is where you're linking to all of our strategic commissioning intentions, and by making it a source document. So
yes, a reference
that's
document.
What it is. That's the thing we should be looking at, which is local, evidence-based for a fair few points in joint forward plan, neighbourhood plan, and strategic plan.
Is that all right?
Yeah. So,
but if I could, Chair,
I didn't rehearse this with the chief exec, by the way.
We need to take it slightly further, which is we are now building a new system of strategic commission.
Yeah.
By April, we need to have that clearly understood how we will commission. There's a piece of work ongoing. Dave is the joint chair of that piece of work with Sarah Truelove from Gloucestershire. This has to become part of that, because we could have this building a new model and then at the end go, oh, by the way, you wouldn't mind referencing that document.
No.
It has to be, how does this become a key input into that process? So I will certainly commit, Chair, we're sitting down with Dave, looking at that piece of work that needs to be done.
Alison, can I just add to that? I think the issue of cardiovascular disease and the Afghan is in the operational group. In a similar way that Joe was actioning the work around alcohol abuse and smoking, that's going down the train. That's a big issue. I, as chair of the strategic commissioning group, want to be able to ask the question, okay, which is, we want to make decisions, policy decisions based on evidence. So what does the evidence tell us? And the evidence is not just the data and the way we cut the data, but also the narrative and the experience. And I think, Shane, this is probably an action for either the transition committee or for us as a collective, as a board when we establish, to look at how we make sense of that evidence.
So I totally agree with you. That's what the strategic commissioning approach is about. The deep understanding of the voices, the evidence. So that's what we're trying to build. And you are correct, it is a transition committee. We've got to bring it back.
There is a but in it, which is it would be very easy for us to do that work as a group of white privileged people. And actually, how do we get the voices of the traveller community, of our African Caribbean community, of people with disability? And I know you know this, I'm speaking out loud of conversations we've had, but we will think we're doing the right things, and we may not be doing the right things.
And also we need to resource it, then, going back to the other conversation we've had.
So I think it needs to be a challenge coming back to us, isn't it?
And that's why I think the 10 actions are so brilliant, because they've been created in a way that are there to challenge us on exactly that point. It's not a couple of people who look like me sitting in a room deciding. Those 10 actions are brilliant because they form the framework for driving this forward. So you're correct, we need to get an inclusive approach to designing strategic commissioning, and then strategic commissioning itself has to be inclusive. two ends, the design and the delivery.
But you can expect from me as the chair of that group going forward to be asking those questions. And if they feel uncomfortable to people, I don't apologise.
So I think I know what it's doing. There's quite a few specific actions in there, which I don't want to lose in the minutes. But Rosie.
Well, there's also a connection to the work we've done with the Race and Health Observatory and Black Mothers, Black Maternity Matters, where the team are picking up around allostatic load and the impact of allostatic loads on women racialised as black in their maternity and birth outcomes. I was going to say great evidence, that's the wrong word, isn't it? But some powerful evidence coming out of that, Joe, that we should connect in. Because I'm listening about your talks about the difference to a woman who are racialised as black and cardiovascular. I think it probably links into this allostatic load piece as well, doesn't it? So Joe, you and I need to connect on that and make sure we because that is our community's voice coming through as well, so we can link that through, Joe.
Thank you, Steve.
So just a final point on that last one. The Health Innovation Network, West of England, cardiovascular is one of the streams. This would be something that could be supported by the HIN in terms of dissemination and spread and sharing that best practice in the same way that we did with AF and the same way we did with Black Maternity Matters.
Yeah. And it's the allostatic load bit that's coming out of that work we're doing with Eastie, absolutely.
Yeah.
Great. Okay. So I'm looking back at what you asked for us at the beginning, which was what do they mean for future commissioning and what are we going to do next? And I think we've captured pretty well what it means for strategic commissioning and what we're going to do next. So unless you've got any closing comments, Joe, I'll summarise and close.
No, I just want to thank this team
Absolutely.
of amazing women, and it wasn't just you, was it? It was a team of 11, 12. So it was a group of 12, so again, it's just 3, but I just think this is amazing, fantastic work, taking a very, very complicated and complex thing and turning into something which we can engage with and do something about. I think it's really fantastic, and I want to thank you very much.
Okay. And on behalf of all, thank you very much, Ruth, Cheryl, Sabinda and Kay. It feels like it's been a bit of a game changer, so challenge us if it doesn't feel that way in a little while. Thanks very much.
Thank you.
Vice Chair as well as board. Sorry? Oh, I didn't realise I was Kay, don't forget your business.
No, that's fine. It would be best to be here. Do you want us to go
Right. Okay.
People turn over.
Thank you so much.
Thank you so much.
I think when they walk into this, it's quite good to me. We don't know how this will just cook it. Should we have some?
We have them.
Well, that's
It got sunny, didn't it?
I'll do that side December.
Who knew climate change?
Thank you so much.
Thank you. This morning, I went out with the dog at 6 o'clock. What was it for the day?
We're going back into big team.
We are. Right, colleagues, should we restart our agenda? Very nice to have Kate and Sav here with us for 6.1, which is update on integrated neighbourhood working arrangements, which we've agreed will be a standing item because it's just really important and interesting. So we've got the paper, you've got us here now, so if you'd like to tell us what you want to, or brief us, or ask us anything you want.
I'd like to make a start. So my name is Sebastian Habibi. Let me start by introducing my colleague.
Oh, hi everyone, I'm Kate Lavington. I'm the Head of Design in the Transformation Hub and I've come to brief you a few times on this.
So thanks for having us. So I'm here deputising for Deborah El-Sayed today, who's our Chief Transformation and Digital Information Officer. I'm her deputy. So the transformation team sits under me. I'll say a few words of introduction, then hand over to Kate to talk through the key points in the paper. I know you've received regular briefings on the neighbourhood health work, which is great, because although this concept isn't new, and the underpinning ideas behind neighbourhood health certainly aren't new, are they? You know, delivering care and support in a more joined up way, a more local level, being more preventative and proactive to improve outcomes. Those are not new concepts. But there was a flurry, wasn't there, of interest in the kind of rebranding of neighbourhood health that came out in the 10-year plan. And we've done a lot of work together, haven't we, to sort of understand what this means locally over the last few months, to focus on the problems that we need to solve and develop a sense of common purpose, but also to sort of ensure that we're clear about our respective roles and responsibilities in moving forward collectively here. So in the last month since we came to board, we focused in particular on that kind of common purpose. We spent considerable time and effort engaging with the Integrated Care Partnership Board, to ensure that they have a voice in developing our vision for what neighbourhood health means in BNSSG, and to be able to convey key messages from that board into the really important work that's going on at at local health and wellbeing board level to develop neighbourhood health and wellbeing plans for our 3 local authority areas. Our focus over the next few months, particularly between now and February, is really on task. It's really on sort of 3 key areas. The ongoing work to support the 2 pilots that we've got in the national programme in Woodspring and in South Bristol, to support the work at Health and Wellbeing Board level to develop those health and wellbeing plans, and to support the work necessary to develop our strategic commissioning plan for population health improvement by February. So we want to focus on task for the next few months. With your permission, we'd like to come back to you for the next report in February, which would give us a little bit of time and space to focus on task. And I'll hand over to Kate to talk through some of the key messages in the paper.
Thank you, Seb. I think that was incredibly comprehensive, actually, and touched on things that I was going to highlight. So I'll keep it as short as possible to allow time for questions. With apologies to Richard, we'll continue to not have neighbourhood health guidance from the centre, and that continues to be quite a confusing picture in terms of different messages. But what the board paper does, and it's really interesting actually reflecting on the last item, we've tried to structure the work in thinking about it as part of the commissioning cycle. So thinking about, as we go forward, how do we need to approach this? So the first thing is an assessment of where we are in terms of how we understand our population need and what we need to do as a strategic commissioner. So we've shared before the Discover report, we've shared the Healthier Together 2040 work. You know, that's our basis for what we understand about our population, and within that we know that neighbourhood health needs to be a key aspect of reducing inequality, really, because neighbourhood is one of the most effective ways. New models of neighbourhood health and care are one of the most effective ways to do that. So we think we're quite clear about that first stage. And as Seb says, over the last month we've been very much focused on phase 2 of that commissioning cycle in terms of turning what we've got, that intelligence and insight about our population, into a plan. And we've been working with the health and wellbeing boards, who in our system are the key partnership forums that are pulling these together at place. And the paper describes some of the outputs of the ICP board session, where we looked at what elements we have of commonality and where we might have differences. And what's important to share with board is that there is really good alignment across our 3 places about what we need to do in terms of neighbourhood health. Just some of the things to flag in that is that there is absolute clarity that we should stop talking about neighbourhood health, it's unhelpful. We should talk about neighbourhood wellbeing and health plans. That reflects the commitment to the plans being rooted in prevention, very much a link to what we were hearing earlier, and the wider determinants of health. Interesting again, based on what we heard earlier, what came out of all three emerging plans is the importance of a person-centred lens. So this ambition to articulate the plans through the eyes of people, to be able to describe what's going to be different, and also enable that to be tested and co-produced. And is that going to work, particularly for our populations of strategic importance? With the plans, all three plans also recognise the need to balance priorities, to balance those wider determinants of health, the things that we want to focus on across all the timelines, with the shorter term deliverables we need to ensure we provide assurance of to NHS England and others. There's a bit in here about the risk of widening inequality. I think the last item did this a lot better than me, but it's really important that the plans focus quite sharply on how the initiatives within them will reduce that gap in healthy life expectancy, and all of the plans focus on the concept of equity of outcome, not equity of investment. And then finally, there is a shared desire to continue to strengthen the role of the VCSE sector. The infrastructure that Ruth described around the VCSE Alliance is really critical, and really seeing it as an equal partner in all levels of neighbourhood planning and provision. So the output of that ICP board is feedback to the health and wellbeing boards, which I said are the engine room to where the planning is coming together in our system. But also we've agreed, because there is clarity and consistency, to develop a shared narrative along the lines that I've just said, because we think it will be helpful for partners who operate at scale across the NSSG, as well as those in place. So in terms of assurance on that second aspect of the commissioning cycle, we would say that health and wellbeing boards are on track, on the basis that we believe the submission for the timescale for submission is likely to be April. It hasn't officially been confirmed, but we are not expecting to get the planning guidance until the new year, so we're pretty sure the December deadline for submission doesn't stand. Phase 3 of the paper talks about how we're developing our strategic approach to commissioning for neighbourhood health. And that very much will be set out in our 5-year strategic commissioning plan or population health improvement plan. That work is currently underway, primarily led by Gemma within the ICB. Our intention, very much as we briefed you previously, is to set out the areas of the neighbourhood approach that we already think we do well and we're quite strong on, areas like MINT, areas like FACE, and also set out clearly within that strategic commissioning plan what are the steps that we need to take over the next 2 years to make sure that we are delivering neighbourhood health at scale by 2030 as we plan in our 2040 strategy. We've rated that as amber. That is recognising the challenges associated with the ICB organisational change and, sorry Richard, the complexity of the emerging national guidance. And then phase 4, how we're understanding the impact of some of the neighbourhood schemes that we already have and we're already putting on the ground. So we've described that through the process of the NHIPs, those 2 schemes, as Seb said, in Woodspring and South Bristol that we're supporting. So I would say to you that both of those schemes are making progress. They're making the progress that we planned. Both have agreed their target cohort and are working through their improvement actions, which we expect will be tested in short, rapid cycles of improvement, which we expect to start before the beginning of January. As I said, that is in line with national expectations, but again, rated at amber because we are seeing that there might be a change in the focus of the programme, and we'll need to make sure our actions continue to align with that. So as Seb said, next steps, neighbourhood health needs to be at the heart of our strategic commissioning plan and our approach to that. We're going to continue to support health and wellbeing boards and draw the emerging plans together over the BNSSG footprint. We're going to continue our support, which is a lot of resource we've put in to support the NHIP test sites. And we are going to actively explore the role of lead integrators that have been established in other ICBs, potentially as a stepping stone as part of our strategic commissioning plan, and would like to come back to you in February, if that would be okay.
Thank you very much both. Just in terms of process, it's there isn't a board in January, and February's closed session, and then March is open session.
Okay.
So I think
it's on the forward plan, even if it's enclosed,
yeah,
so that we have regular answers.
That's great. Great, thank you both very much. Comments and questions, colleagues. Jaya?
Just wanted to observe, I guess, the fact that you've got a neighbourhood-based, geographically based plan, and then, of course, the piece that we had before was very much about communities. And how are you working? Because obviously communities are spread between different places.
Absolutely.
They have different focal points. Where does your work meet with the communities-based work that Jo's been championing?
Absolutely. So one of the points I could have drawn out from the ICP discussion was about that tension between geographic, neighbourhood and communities, which don't necessarily form around perfect geographic lines, particularly communities of interest and communities of inequality. A really good example of how that we've thought about that is the MINT teams. So MINT teams are not just geographic, they also have a functionality that supports particular communities of interest, communities of inequality, and that seems to work quite well. And so I think the view is we would need to be able to allow for that in our neighbourhood models. And one of the things about thinking about how we might explore an integrator is that there are some things that are best done not on a geographic footprint. And we'll need to make some, part of the steps within our strategic commissioning plan will be how we make some decisions about that, taking into account an options appraisal.
Yeah, thank you. Because I guess thinking about the 10 principles that we were looking at before and how that could be a wraparound for the strategic services that we want to commission, how will we make sure that that applies to both ends? I guess it's just trying to make sure that we've got some kind of continuity between the two. So it's a challenge for the board going forward.
It goes back to the fish in the water concept.
Yeah.
So what you heard there was the description of the colour of the water, but within the place you might have a shell with fish.
Yeah.
So just to stretch it, but it's that concept. Both things can be true, but they all have to be enacted within. So the role of the ICB was to set a 5-year strategic commissioning environment. It's designing the colour of the water, and an expectation with my CMO how will people adhere to that, and they work within those parameters. But how they do that, there's massive freedom. So it can't be completely locally determined, but it is locally determined. So you've got these slight sort of paradigms going on.
And to bring it back to my badly made point about communicating to those different groups, different fish need different bait, so we need to work it out. Yeah.
We're gonna have to build.
Can
this.
we do that?
We might have a picture of this.
I'll run with it. We've got lots of people who want to come in now. So Shane was first, then Jeff, and Joe and Steve.
Yeah, just firstly, thank you to Kate and Seb for the work that's going on. I think it's an interesting point of governance and ownership that this board and the future board will need to think about. The health and wellbeing boards have primacy in this. They are the ones who are looking at their place and saying, how do we develop well-being and health plans? We have a duty to bring health care to those places. And it's just trying to find that balance, because actually we'll not be the ones who'll be owning Bristol's, to take Bristol's example, Bristol's neighbourhood health and wellbeing plan. We'll be owning the bits that we commission with regards to healthcare, and actually the guidance, we haven't seen it, but the guidance likely to come is going to be very NHS specific guidance. It's going to be about neighbourhood healthcare centres. It's going to be around the role of primary care and the integrated neighbourhood team in primary care. So I think it's great, and we need to feed in to health and wellbeing boards, but this board needs to be clear about what it's commissioning from a healthcare perspective to feed into that. And as a board, we might be a servant of the health and wellbeing board And that might feel a bit odd. Okay, so we just haven't quite worked that out yet, but it's very clear we, this board, cannot own the 3 neighbourhood wellbeing and health plans in its whole. We need to serve them rather than own them, but we own the health care side of those plans. So it's not as simple as one plan, unfortunately. But Kate and Seb, thank you for making sense of that at the moment.
Thank you, Shane. Jeff?
Thanks, Shane. I think that was a good explanation, and thanks to Kate and Seb. I know at the ICP we had a long conversation about this, but we were presented with 6 definitions of neighbourhood, and then within that you've got place and community, and it all triggered that conversation that Jay has just presented to us. So I don't think we're going to get a common definition because everybody wants to hold on to their own definition, but I think us using the same language about what we're talking about. Are we talking about place? Are we talking about the Work of the Health and Wellbeing Board? What are we talking about? And I think if we can try, I don't know if you've had any progress with that, but if we can try and nail some of that down, it will mean that things don't drop off the side and we don't duplicate conversations, because they all mean different things to different people. So I don't know whether we've got any further than that at all.
Well, we have, so yes, we have agreed that we want that. I agree with you, it's not about shared definitions, it's about shared use of language. We've got 2, what would you call it, versions of that, which we're engaging with at the moment.
Yeah, that would be helpful.
Great, thank you, Jeff. Jo?
Yeah, sorry, my head's hurting slightly because I'm just thinking about all of that, and the point in your slides about digital, because that, you know, the generation of the future is digital. Where does that sit? I'm just thinking, because some of the digital expertise will enable people to directly communicate with their acute trust partner and wipe out some of the need for the middle bit. Some of it will be that actually the middle bit can be the thing that prevents the acute bit. And then there's the whole stuff we've talked about around inequalities and access. How will that work in your view?
If I may pick that one up to start with. So we've recognised in our sort of programme approach that we're developing to support the delivery of neighbourhood health that we need to address the questions of, you know, what does good look like for digital enablement of neighbourhood health. We are just beginning, so I didn't emphasise it in my task for the next 3 months, but we are actually beginning at this point in time in a discovery to understand what the problems are we need to solve in terms of digital enablement of integrated neighbourhood health and what the solutions, you know, might be. We've got some things to build on, Joe. I mean, we have got a shared care record system, we have got a shared care platform as well, which can potentially be adapted and adopted at a neighbourhood health level. My suspicion is that none of the tools that we have will be good enough ultimately, and that the discovery will probably show that we might want to commission, as Kate was alluding to, a lead integrator, for whom one of the jobs we commission might be to procure and build a more bespoke platform, you know, that provides the digital environment for the team of teams that work at a local level that, yes, may be employed by organisations, but increasingly will be doing their work together at a neighbourhood level, and will need a digital environment that doesn't just enable access to information, but actually enables them to communicate, to move tasks around, to have a holistic view, to pass images around, and so on. So I think that we haven't seen what good looks like yet in terms of digital neighbourhood health. We need to go on a discovery, and we probably do need to commission for solutions as well as adapt what we have in the interim.
Can I come back? Just thinking about that conversation that we've just had, generationally, our kids are going to engage differently with it. So I'm not sure we're solving a problem, but looking to what the future model needs. So I'm just thinking it might not be a neighbourhood model, because actually there might be a load of stuff we can carve out on digital that frees up capacity to spend on the neighbourhoods where we need to spend it. So it's just trying to do that in alignment, so where we've got those abilities to do things and people engage and manage their own health, we can then spend our money where we really need it. Does that make sense?
Yes.
Thank you, Joe. Richie, was on this point or a different point?
A different point.
Okay, so I'll bring Steve in first, if that's okay.
Thank you. I was just really interested in Shane's comment as well about the changing relationship between the health and wellbeing boards, neighbourhood plans, and this board. Part that got me partly thinking about what are some of our levers of authority, I guess, in terms of trying to influence some of what happens. And one of those things is understanding what should we be commissioning just once across the whole of the ICB footprint, what needs commissioning at local authority level, and what needs commissioning at neighbourhood or place level. And having some of that kind of spell that I think would really help, because again we talked about, you know, and again one of the challenges I think is we sometimes take a system-wide approach to addressing a single illness, whereas the place where a place where it can really come into its own is where you bring people with different elements together for a common solution. So I think how we carve that out is going to be really quite challenging and interesting. And actually I think that's what can balance the scales, if you like, in terms of the nature of the relationship with the health and wellbeing boards, because it does feel a little bit like a power battle at the moment.
Yeah. If I may, so I'm wondering, Steve, I don't know how we do this, whether there is something that sits above the 3 health and wellbeing boards to keep them within the guide rails. If you know what I mean. So in other words, if we allow the 3 health and wellbeing boards just to go off and do, I think then providers will be confused. So it's whether the ICP can play that role. Now I know what the 10-year plan says, which ICPs are disappearing, but there has to be something, because you're dead right. It does feel a bit like a power battle, and that's why I talked about us being a servant of the health and wellbeing board. But ironically, everyone on this table could be the bit that sits above it, as a bit opposed to that sits below it, and we haven't quite worked that out. And I share your concern that I think health and wellbeing boards individually are accountable for their individual place and our individual elected representatives, but it might not be the same for BNSSG as a system, or maybe BNSSG and Gloucestershire as a system. So I think there is something. Myself and Joe had this conversation last week. What is it that sits above this to make sure it's not going in radically opposite directions? Allowing for people to make local decisions, but it can't be just a free-for-all. I don't have the answer yet, but all I know is if we don't put some kind of guide rails on it, it could end up being we just can't serve that.
That is something we're going to have to create.
Yeah.
Because the ICP as it stands at the moment doesn't do that.
No.
And the ICP has got a number of people from around this table, but chairs in there. And actually in the new world, there's no place for chairs to have that conversation. Now we used to do that as an STP board, where we had chief execs and chairs came together as a group. It might be something like that. I don't want to create boards for the sake of boards, but there needs to be somewhere where we're having a partnership conversation. There has to be.
And I mean, we didn't even talk about the acutes as part of that as well, because that's another massive piece of the puzzle.
Yeah. Thank you, Steve. Richard.
Yeah, Kate, you referenced the lack of guidance. I think conversations like the one about neighbourhood place just shows how dangerous it is to think you can write this guidance at this moment, because we're on this massive learning journey. So I think what I'm hearing from our team at the region is they've got real confidence in what you're doing in BNSSG. Shane always says write the plan for BNSSG and then feed the other beasts where you need to with that plan. So I think have your plan. That's the priority, I think, and we'll work with you and provide some advocacy for you around this is the right plan for BNSSG, and we'll feed the beast on that side. Is that okay, Kate? And we'll work with you on that as best we can.
Thank you so much, Richard.
It's interesting because we had the first update, it must have been maybe a couple of months ago. We haven't got local authority colleagues here, but the comments, I think, very positive, but there's quite a lot of existing stuff already, and where are you going to find your place in all of this? And it does sound as though we're getting there, Shane, with that description you described, but actually there's still a bit more to go, but it is moving each time. So Joe and Joe,
Yeah.
both hands up.
You were first.
So I think there is something about how myself and the 3DPH has worked over the past 3 years. We have had to work this through a little bit through our professional lens, and you know I talk about the advocate, lead, contribute, partner lens, which came from the National Public Health Director, Sarah, something like that. But it is a really good model, because again, even with something as tiny as hypertension compliance, look what comes out as the factors, which goes from a healthcare outcome into the wider determinants of health, which you said. So it is all intimately linked, but I am accountable as your Chief Medical Officer for the management of cardiovascular disease, primary and secondary outcomes. It sits with me and through me, and Shane has overall accountability for it. That is our leadership role. But actually, access to exercise, I should be a partner or a contributor. So that language of where you put your skills and what your role is, and it allows Shane's concept of that we are servants, but also set the parameters. If you have that as a way of thinking about your role, that works. You can do it within that span. And I think the relationship between the 3 local authorities, DPHs and myself, we've worked that through and we found that works for us. So we would advocate that slightly simplistic methodology, but it allows you to see your place in the agenda topic that's being discussed. So it can work, but you just have to be disciplined about not everyone having a leadership opinion, maybe about something where they actually should be partnering or maybe just contributing. So I just keep that in people's minds.
Thank you, Jo. Jo?
So I'm just conscious that in this conversation, and it's referenced in the paper, but it didn't come up in the discussion, is that to make all this work, we need a really strong workforce that has shifted significantly, both how it behaves and where it belongs. Because the current kind of construct of I am an employee of an organisation whose purpose is to do this is not the reality of how we want to now deliver those services to our patients. And in your paper, Jo, it references the fact that that workforce needs to be very truly representative of the population that it is serving, and we don't have that either. So I just, in whatever model it is and whatever overarching governance we have, that is the people element is a really strong feature, as strong a feature as the patient voice in what needs to be different.
Thank you, Jo. Lots of, I see Kate writing there's lots in that, isn't there? You've asked us to note the updates. You've asked us to consider and endorse the next steps, identifying any additional work programmes we're taking forward. I hope the discussion has been helpful. I feel each time this comes, it's just evolved a bit more and a bit more in the right way. So thank you very much. And we will see you in February. Thank you very much.
Thank you.
Thank you.
So Seb is staying for the 6.5 item, so I thought to be kind, we'll just do that next. So Seb wasn't expecting to stay all day, so then we can release him to
Yeah, good.
So we're going to do thank you very much, Kate. We're going to do 6.5 now, which is the Innovate Healthier Together programme. Seb, do you want to... Are we expecting...
Rob's just seeing if we're expecting anybody else.
Well, actually, if we're expecting visitors, Shane, do you want to take us through 6.3 and 6.4?
Yeah, certainly. So there are two policies, two committees, that are being revised. The first is the Transition Committee. So you will see from the covering, 6.3, you'll see from the covering paper that we revised the terms of reference, and it was identified that the terms of reference of the committee didn't have a chief clinician as part of the process. I approached the 4 chief clinicians across the 2 organisations, so the 2 CNOs and the 2 CMOs, for them to self-nominate who should be on the transition committee. Joe Medhurst, our chief medical officer, was nominated, and therefore the terms of the committee need to be changed. They're formally approved by this board chair, so the board needs to approve the change in the committee committee structures.
So anybody not agree with the change?
She's just leaving.
I think we're all agreeing. Jo, thanks very much. Yes, we're noting the amended terms of reference for the Joint Transition Committee and a good amendment there. And the Joint Remuneration Committee terms of reference?
I'll pass on to Rob just to describe what's in it.
And so as under the scheme of reservation and delegation for BNSSG board, same is true of Gloucestershire board. The intention as part of clustering is to create a joint remuneration committee, and therefore the terms of reference for this committee are here today for approval, and I think they've either been to or are going for agreement at Gloucestershire as well. This committee will replace our BNSSG remuneration committee. You can see from the membership that there are members from both this board and from Gloucestershire's board, and this is the sort of thing that if we were merged we would have one remuneration committee, so it's trying to get into that joint cluster governance, and this is an output of the governance work stream that has been established through our joint transition committee, again with Gloucestershire, that Jeff is chairing. So I'm happy to take any questions, but what I'm hoping you're going to say is, this makes sense, yes, And then the document, both these last two documents will be placed onto our governance handbook on our website, and I'll make those arrangements.
Thank you, Rob. Do colleagues agree with the amended terms of reference for the Joint Remuneration Committee?
Yeah.
Yeah.
Thank you.
Good. Thank you very much. Have we established if we're having any guests?
We're not.
No, that's great. Okay, that's good. So are you happy, Seb, to take us through the Innovate Healthier Together programme?
Yeah, absolutely. Yeah. Me again. So, Innovate Healthier Together is a programme that has drawn to a conclusion. And what we're asking of the board today is to note some of the key findings that Health Innovation West England have distilled from their interviews and their analysis and the time that they've spent with us during the Innovate Healthier Together programme, and also to look ahead to the recommendations of the next steps, which are in particular about how Health Innovation West England continues to support the development of innovation as we move forward with our organisational changes and develop our role as a strategic commissioner. So a bit of background. What is this all about? Back in 2023, with the support of the System Executive Group, the ICB commissioned Health Innovation West England to support us on an Innovate Healthier Together programme. It had kind of 4 areas of focus. One was about culture change, developing an innovation mindset. The second and the third were about developing examples and learning from examples of innovation push and innovation pull in BNSSG, and the fourth one was around understanding what we might do about some of the perceived barriers to innovation, adoption and spread across the system, and that sort of system level of innovation is important. At a provider level and an individual kind of clinician level, innovation happens all the time. Our acute hospitals are some of the leading innovators in the country and indeed in the world in areas like genomics. And we know that. What perhaps is more challenging is innovation across organisational boundaries, innovation at a system level, and indeed commissioning for the environment that fosters innovation, adoption and spread. So the focus of this work, in particular with regard to barriers and opportunities, was on innovation at a system level. So what's been achieved? Well, firstly, in terms of culture change, one of the key things that the programme has achieved is it's brought together innovation leadership community across Bristol, North Somerset and South Gloucestershire. It started at an event that Steve, no less, chaired himself back in 2024. It's called the Innovation Fellowship, and it's a community that's ongoing. And Health Innovation West England, in the proposed next steps, have proposed that they can continue to support that community as essentially a free of charge offer as we move forward in our cluster with Gloucestershire. So I hope that's welcome for the board today to continue to support that fellowship. What about the second and third areas then? Innovation pull and innovation push. We had the beauty of coincidence at the time that we were sort of establishing this programme. We were also able to apply to NHS England for funding from something called the Health Technology Acceleration and Adoption Fund, or HTAF for short. And we worked with one of our clinical leaders, Sandra Shah, from the Acute Trust to develop and test a model of innovation for people living with chronic obstructive pulmonary disease in BNSSG. And when you don't get everything you want, you sometimes get a lot of experience. And that was my takeaway from the project, although there were some notable successes in it. Firstly, it showed that we are able to come together across system organisational boundaries and stand up innovation quickly and adopt a test and learn approach to innovation. We stood this programme up within less than 3 months. We tested 2 types of technology in an integrated care pathway for COPD, and we achieved significant results, particularly in terms of the presentations at ED. Significantly reduced presentations in ED as a result of this innovation compared to a control cohort. So we know it had impact. The thing is, we'd set out an ambition to save bed days. And because we couldn't demonstrate that level of savings, we couldn't make the business case to invest further, and we brought that project to a close. And so we got some impact, we got a lot of learning. And one of the reflections that Innovate Healthier Together have highlighted for us is that when we do set out ambitions before we've tested and learned, before we've experimented, and they are kind of hard-edged and financially driven, they can have the effect sometimes of curtailing rather than fostering the continued iteration of some of these innovations. And that certainly was the case with that project, which has been closed. The report also talks about some of the challenges we faced with Innovation Pool. What we did was that we looked at the work of the locality partnerships. We attempted to identify opportunities, if you like, to link innovators to the things that we were trying to do at a locality partnership level, with mixed success, I think I have to say. And then in terms of procurement barriers, again, we've learned a lot about some of the challenges that we face in working within the rules, and one of the I think important developments that's come out of that work is that the opportunity to work with innovators, to work with business ahead of procurement presents opportunities also to sort of help us navigate those procurement challenges when they do arise. But them's the rules was one of the motifs that we heard from Health Innovation West England in reflecting on some of the difficulties in reconciling procurement rules with the idea that we work with partners in business to innovate and test and learn. So in conclusion, what are the next steps? I've mentioned continuing the fellowship, that's number one. Secondly, to work with us in what's proposed to be a system innovation collaborative. It's a way of working that enables us to continue to engage with Health Innovation West England as an integrated care board as we move forward into the cluster of Gloucestershire, but also with provider partners. What that will do, twofold, it will enable us to benefit from Health Innovation West England's ability to horizon scan and help us identify and commission for innovation going forward. It will also help to maintain a dialogue between Health Innovation West England, the commissioners and the providers about the problems that we're looking to solve for innovation and bring together that push-pull dynamic. So in conclusion, we'd like the board to support the work, to note the findings that Health Innovation West England wish to share, and welcome the support of Health Innovation West England to take forward the next steps in those two areas I've outlined, maintaining the fellowship and establishing the collaborative going forward.
So thank you very much indeed. Comments and or questions, colleagues? Shane?
I co-chaired Innovation Health Together with Tasha. And I think my initial reaction at the end of the year, we all put our shoulder to the wheel, was a bit of disappointment, really, because I thought we started with this great ambition. We'd 4 work streams. We wanted to see the world change. And then I think in the reflection, we went, it was only a year's worth of work, and we have achieved a lot. And therefore, the aim is to create the collaborative to try and take that on a bit further. Absolutely, the collection of, I think it's 126 people now as part of the fellowship is creating a social movement, which is great. But what I would really value is another couple of years working with the HIN to really try and accelerate this. Because I think we set ourselves a target in 1 year to fix 4 big things. I think we did 1 point something, I'm going to be perfectly honest. And that's okay.
That is, yeah.
That's okay. And therefore, I think we need some more time to try and bring more system partners in and really try and drive system innovation. It's not to take away from individual organisation innovation in AWP and in the Bristol group and in Sirona, lots of that going on. We're not trying to play in that space. What we're trying to understand is what could you do across the system rather than within organisations.
So important to note the progress from the last year, full stop, but we're continuing. You would recommend that we continue for the next couple of years and review again? In the different format of the collaborative. So we're not trying to do all 4 things, and in the collaborative. Absolutely. Thanks, Shane. Jaya?
Just a quick question about how this works with other innovation groups around, because you were talking about scaling as well, and how can we take advantage of what's going on in other areas that would enable us to reach more?
Other areas like outside the...
Yeah, that's geographically, yeah.
Couple of things I'd say on that. I mean, one of the opportunities we grasped at the back of this programme was we got onto a Health Innovation Accelerator programme that is creating an opportunity to share learning with other integrated care board areas and their innovators. I was a part of a workshop in October where we were doing some of that shared learning actively, and we will shortly receive a report, I think, to be published later this month from that work. On an ongoing basis, I think the role of Health Innovation West England is really, really crucial, because they do kind of provide some of that horizon scanning for us, and they work with the national team and they work with other areas in the west of England and other networks to help us understand understand, what's out there and what the learning opportunities are from other areas. But it is an inherent danger that we have a bit of a tendency sometimes to have our head down and look inward, and I think it's a good challenge, Chair, that we need to be looking outward as well.
It might save us from, making mistakes that have been made by others already, so at least we can help navigate.
Yeah.
But thank you, it's a good body of work, and I certainly support.
Thank you, Jane. Steve?
So I should declare that I'm the chair of the HIN. That's some transparency. The HIN works with the other HINs in England, so it's a network of 15. So nationally we're connected, and that's the whole point, that we don't reinvent things in each one. And so there are some national imperatives, and also we can feed into some of the national pool. So if we spot things that work here, we can take that and put that forward into the national framework to be adopted and spread across the whole country. And we've had quite a few successes in that space. The other thing, I guess, is that the fellowship it is a movement, you're right, Shane, and what it's doing is allowing individuals from different organisations, the acutes and in primary care, to come together to do local innovation and be supported for that. We're just in the process of working through our future look in light of the changes in the ICB landscape. So we'll be watching and supporting, at the moment, 3-4 ICBs across our patch, because our geography is slightly different, of course. But we will also be working very closely to identify what the plans are that are being put forward from each ICB. The HINs then are required to put their plans in, but we don't need to sign ours off until June. So it gives us an opportunity to make sure that we've got the alignment and the priorities right. So I guess what I'm saying to this board is that we'll work with you and alongside you with the others, Gloucestershire and Bath, Somerset and Wiltshire, Swindon, to make sure that our plans work alongside your plans, and the timing is quite helpful for that, for a change. It actually works, which is fantastic and unusual. And I think there is a momentum. The final bit, of course, is innovations happening elsewhere across the BNSSG patch, and we network in. So remember that the HINs are about provider organisations, ICBs, they're about industry, and they're about academe. And it brings the three bits together.
So where do we see this stuff percolating through? Because we all need good news stories right now.
So we can bring them, and then the HIN does publish it on the website. So we've had a number of successes. Interestingly, AF treatment was one of the early ones that we actually did as a HIN, and that was about recognising that there was a lot of atrial fibrillation that was undiagnosed in GP practices and then not treated.
Yeah.
So that was one of the first ones that was picked up nationally and then rolled out nationally. Another one was magnesium sulfate in magnesium sulfate in premature births, and that was a big one. And then there was the final one around maternity, and it was dislocation in shoulder dystocia. And unfortunately, Tim's, I read last night, passed away.
Yeah, passed away last week.
Yeah, very sad. But he was a fantastic supporter of that sort of innovation, practicing innovation and then rolling it out.
Because I think certainly going forward we should be communicating some of those positive things that could be coming through. It would be a fantastic way to sort of engage and hopefully build trust.
The COPD one, although we beat ourselves up, we moved at breakneck speed with that one, and it was sort of trying to get ahead of winter pressures, if you remember, and trying to monitor patients in the community. And inevitably we learnt a huge amount. There was some early resistance from consultant communities, but once you get them on board, we were able to move. I think we probably didn't see the full impact because we were in the middle of the winter pressure when it was actually rolled out, and I think that was probably a bit of learning for us.
Thank you, Steve. Maria.
Always keen to promote innovation and accelerate wherever we can. I do think sometimes some of the blocks it's quite a difficult environment to navigate. There are so many things. There's an artificial, I think, occasionally separation between research, development, improvement and innovation. They all have their separate routes up to NHS impact, NICE, etc. So it can be really difficult actually to get ahead of steam around it. And I do wonder if it's worth just locally and regionally having a look at the picture that is out there to make sure we're not dissipating our energies and resources, because there are fantastic things. Rosie and I were talking about it earlier. We're not on the map for some of the things that Steve just mentioned.
Linking the shoulder dystocium, magnesium sulfate to our neonatal and maternal
Yeah.
stillbirth.
Absolutely, where
They are connected, but
Yeah.
somehow we're not connecting what we've done and the impact and them being as loud, I think, as we should be.
And they're all sitting in slightly different camps that we're not pulling together. So if there's anything that we can do that does help us pull that together, I'd be very supportive. And of course you've got Bristol Health Partners and a number of other agencies who sit in the same space with people perhaps, terms of reference overlapping a little bit perhaps.
So is there a specific action based on what Maria's just said there?
Yeah,
Shane?
if I may, I mean, certainly Steve and I had a brief conversation probably 4 or 5 weeks ago now, that there is duplication in the architecture. Okay, there's lots of different organisations, whether that's Bristol Health Partners, Health Innovation West of England, the stuff we're doing, Innovative Health Together. And actually, if we were to get a number of leaders, you're very active, obviously, in Bristol Health Partners, to come together, could we create a single architecture for the identification and improvement side? And I think it would be really helpful, because I know we've lots of different architecture. So, and I mean, I think we do need to bring, Health Innovation West of England, others in and say, right, what is the single architecture? It doesn't mean that we're going to constrain people by it, but we're all giving resource to different things, which are all trying to achieve the same thing. So I'm more than happy to take that on from the ICB perspective, to coordinate even just a baseline of what's out there, and then suggest a way we can start to bring these things together. So I'm more than happy to.
Thank you very much, Shane. We'll capture that. Steve, final comment from you.
Yeah, and Maria got me thinking, because again, I think often we get stuck on barriers, and I was just trying to think about, what are the enablers to innovation across organisations, and are there 1 or 2 examples of where we've seen it that we could start to model a little bit? So it got me thinking, rather than getting stuck on barriers, how do we find a few enablers that can allow us to test and continue to move forward?
Thank you, Steve. Thank you very much. Right. Okay, so we're being asked to receive the evaluation report and support the proposed next steps, which I think we do. Steph, thank you very much for briefing us on that.
Thank you, Steph.
And all the work in between. Thank you very much. Colleagues, do you want a 5-minute break, or do you want... You do? Right, okay. So we have there was loads of nods.
There wasn't even a response to that. I was just,
there was just nods all on the left-hand side. So why do we come back at 25 to, just to stretch our legs?
Thank you.
Nice to see you, Seb.
Hi, Seb. So we start then as soon as we can.
You sounded defeatist. Jo's gone, I think.
Gone.
She's,
She went
yeah,
to-
Jo's gone.
Oh, Joby.
Oh, sorry.
We'll recommence the board at item 7, which is our update from committees, which is our usual practice. What we'll do today is, John, if you could do audit and risk committee first. I know you may need to leave slightly early, so.
Thank you, Alison. Thank you for looking at the agenda. I do have a good reason for abuse tonight. Meds. I've got to get home by 4 o'clock to join Gloucester Hospital's Council of Governments, which is due to run at 8 o'clock. Yay! Anyway, in terms of audit and risk, these minutes are from some time ago. It's the September 25 meeting, and we are due to meet next week. But just a couple of points that I wanted to pull out. It was just to confirm that we remain well on top of the audit tracker. And given everything that's going on, this is very much appreciated, and all credit to exec colleagues for everything you're doing. And it's important to remain on top of this, as in effect, if we're delivering to the annual internal audit recommendations and timescales, we are well placed to achieve a good head of internal audit opinion, and it's something we've always achieved in BNSSG, and I'm keen that we continue to achieve that as we head towards clustering. We just had the one internal audit report that was on funded care, and it provided reasonable assurance, and given our transitioning to greater focus on commissioning, it was good to see the report and good to see that we start from a good place with lots of good practice and in a position to build on this. The internal audit plan we review each time. We had built a degree of flexibility into it, but it's continuing to provide good coverage, and we included capacity for some transition work, and we will see this delivered towards the end of the year, and that will be in partnership with the Gloucestershire ICB internal auditors as well. In respect of the corporate risk register, we noted some concerns around the achievement of the All in McGowan training across the system. We were keen to see that addressed, and we did address that as part of the action tracker at the start of the meeting, so that is in good shape. And final thing was just, we have been monitoring the new ISFI2 finance system through audit, and we had a report from Matt last week at Fed that it had gone live, and that the go live had gone pretty well, all things considered. So it was really just to say well done to everyone, particularly to Matt and the team, given everything that you're trying to deliver and land at the moment. So those are the key points. Thanks, Jeff.
Thank you, John. Any comments or questions for John and Audit and Risk Committee? Thank you, John. Outcomes Quality and Performance Committee. So Ellen has sent her apologies today. I know that she has raised the importance of the winter plan and the scrutiny that the committee takes. The next committee meeting is on the 11th of October, and that's expected December. Expected quite a main agenda focus, so as you would expect, that will have a good airing. In terms of the outcomes, quality and performance report, we have got reports sitting below them. Rosie, is there anything from the quality report that you would pull out on behalf of you or Joe?
Some of the quality reports not being uploaded on Diligent and nor the minutes, so we have got a bit of a gap in the papers being submitted today, and Rob and I discussed that. We'll sort out how that's happened. I wasn't actually at the last committee, but I know, as you say, the winter plan was a strong focus there, and just for board assurance, it's also then been through a meeting in common of the system quality group and the HCPE for validation by our senior health and care leaders as well, so that's happened just so board's aware. There are no new quality and safety risks. There is quite a high focus, as you know, Alison, about infection prevention control and a couple of areas around C. diff and MRSA particularly, which we're doing some more work on because we tend to, well, we don't tend to, we are an outlier, particularly MRSA, and we're doing some more work with region on that at the moment, but nothing new. Thank you.
And 7.4 prevent policy isn't going to be discussed?
Yeah, it was approved and endorsed by committee and recommended to come to board, but unfortunately the copy that was uploaded was not a fully finalised version, so I don't think it's appropriate for board to try and approve that until you get the correct version. So apologies from us on that.
That's fine. Thank you, Rosie. Dave, on the performance report, is there anything you'd like to pull out?
I mean, we've discussed winter already. In terms of the performance report itself, though, I just note continuing strong performance on RTT, diagnostics, cancer, the majority of mental health standards. So it's really positive news for the system. We've already changed up about winter earlier, and the importance of continuing to push the vaccination programme. I've just seen from the news while we were on a break that there is now a reported national peak ahead of schedule of flu. So this is going to continue to be an issue ahead of Christmas, which is kind of an unusual pattern. I think the only bit I'd add, Alison, is that a key element of our winter plan is our continued focus on reducing no criteria to reside within acute and community settings. Delivery of our winter plan is contingent on progress against that, and despite significant efforts from all, we are currently off plan against that. So I flag it here today because the importance of partner support across acute, Sirona and local authorities is key to turning the corner on NCTR. Our continued particular focus on reducing P3 length of stay, and so I just raise it here because I know Ellen would want to, and to emphasise the importance of that continued partner support and senior leadership of focus in trying to address that issue for the system. Thank you.
Thank you, Joe.
Yeah, sorry Dave, I know I said I'd catch you today and I haven't caught you yet. So I've been trying to look at our role in no criteria to reside and where we are with it, and following our meeting last time. And I know that we've got an Empower report pending, which I haven't seen, I haven't had time to talk to anybody, but my initial assessment, having looked at the level of no criteria to reside in the acute trusts and the way that we do business together, is that there are so many own goals that we could, if we work together as senior leaders, we could fix them. So, and I'm not trying to oversimplify it, I talked to Maria very briefly today, but when I look at the numbers and I'm trying to work out how and where we push the levers, a third of the no criteria to reside technically sit under Sirona as P1s and P2s. P3s belong to local authority but are only assessed as P3 when we've said they're not P1 and P2, so we've got a big inbuilt delay, and I don't know why we wouldn't just say they're a barn door P3. They're never going to go home, they're going into a care room or they're going somewhere for end of life, so we've got a built-in delay there. We've got fragmentation between CHC, and I'm sure you all know this, but these are things that actually if we integrated some of the exit out points, I think there's stuff that we can do together, so I will catch you. And from a community hospital point of view, our average length of stay is about 31 days, but it fluctuates on different units. If we get it to 28 days, we can deal with the demand that's coming through. I don't know what the number is to get it to take the backlog away. I've asked them to look at that, but I've talked to my team about that's going to be the big priority for us for the next quarter. I'm going to ask the medical leads in Tirona to go and do some point prevalence audits with some of Maria's team, with some local authority colleagues, so we can understand who needs to be in the bed and where they should be. And finally, we don't have any admission criteria for the community hospitals, so everything comes. So even if that patient's going to be a P3, they're going to stay with us for 2 months while we get a P3 bed. I could have cycled 5 patients from a P2 through that pathway. And we're very P2 orientated. And actually we're probably putting people into long-term care because we're decompensating them through all the different hoops, and we could invest and spend the same amount of money differently. And I'm saying that in a simple way, but I think there's low-hanging fruit.
I think what's really reassuring is you've got fresh eyes, you're coming from other experiences where you can clearly add to us, and so it says actually our work's not done, there are improvements that can be made.
Yeah.
So that's really positive to hear actually. So thank you, Jo. Maria.
I can't tell you how much I welcome Jo. So rather than my usual broken record, which of course is exemplified in a critical incident, again MBT for the last 3 days. Huge amounts of effort have been done, so thank you to all system partners. But again, it's always convened under Dave. Great escalated surge effort that then goes away again, and we just can't afford for it to go away again. So this really is the chance now, I think, for us to look differently at risk thresholds, trusted assessment models, doing things once, standardising what we're doing, using our resources, because I think we all believe probably we've got enough, but it's just in the wrong place. So I think we'll be going at this with renewed vigour, won't we, Jo?
We will. One more point, sorry, I did contact Tim Briggs in week 2 to say I need to go for the community. We're not entitled to be part of the top 14 trust that will be GIRFTed, but they've said that we can run alongside it, take all the learning, and I can put some of my team through that progress, and their priority is Q2 length of stay and target, so we'll work together on that.
That sounds great.
Amazing.
Yeah.
Is that as a sort of Q Trust associate or something?
No,
Can we
it's
do a model like that?
Well, it's a national. As you get GIRFTed for everything, they don't tend to do community.
No.
So I emailed to say to Tim and Graham, are you GIRFed in the community? Can we be in the first, aliquot? Because I think there's some stuff we do really well, but we don't share because we don't share our data well with you, which we will do. And then there's some stuff which we know we can do better on, and we want to be at the forefront of fixing it. And they said, we're just starting a programme. We've spoken to their community expert, who said because we're a KIC, even though we provide a lot of NHS, required services, we don't count. But because we've worked with Tim in the past, they want us to be part of it. So I think it's about driving the NHS level of drive that you have in the acute sector, which I'm really keen for my staff to experience. And then we'll join it up as part of the pathway.
So for those who don't know, GIRF is getting it right first time, and it's an improvement methodology and consult, it's better than I, but it seems to be very positive in terms of its outputs. But again, there was some talk some years ago about primary care getting it right first time as well, so which hasn't materialised at the moment, has it?
Yeah. I think my experience is it's been very elective focused. It's a little bit of acute and it's moving into community.
Richard.
Can I just note the reference to the CICs and being out with... We're finding this on a number of fronts where systems are reliant on partners who are not traditional NHS models, and yet they're treated as if they're something different. So I'll take that back again and say, look, can we pay attention to this more? Because we've got a number of our systems across the southwest with major CIC and other partners who just need to be seen as part of the system, really.
Right, thank you.
Can I just add that ties in with the VCC Alliance as well in terms of some different ways of recognising engagement with the ICB.
Thank you.
Can I just ask whether or not there are any action points for our board that would support all of that lovely stuff you've just said? Because I don't want to lose it.
Yeah, I think that your performance report is what I'm responding to, which is we've got a no criteria to reside problem. All roads appear to lead to Serona, but actually all of the no criteria to ride isn't currently all about Serona. But actually we don't articulate that between any of those, and I couldn't get to grips with it for my first 4 weeks in post, and it should be straightforward. but the relationships we need to be having and building and the conversations don't need to happen in here. We should be getting on with it outside and bringing back the solutions here. And I'm really sorry if everyone's already done that, but while I've got the ability to see things before I get lost in the the data, I just want to make sure that we have a really good crack at it. I think
That's
there's
really
loads we can
good.
do.
Thank you very much, Jo. Great. Okay, thanks, Dave, for your update there on the performance report. Jaya, is there anything you want to update on the People Committee?
There is indeed. So this is to do with the ICS People Committee that we had last week. There are already minutes for the previous two meetings, which were ICB and ICS, but they're already on the system, so you can have a look at that. Quick workforce monitoring update. Our total staff, including substantive and temporary staffing, remain above plan, with a reduced turnover rate of 10.7%, which is 2% lower than this time last year. Sickness absence in October is 5.2%, the same as last year, and we continue to focus on temporary staffing, which is currently 5.9% over plan, and this is being closely monitored with the impact of industrial action and winter pressures. Also, to cover people response to HT 2040, the strategic workforce team commissioned by the committee conducted a roundtable with system partners the other day to develop an integrated workforce development framework. And this framework aims to prepare our current and future workforce, emphasising readiness and adaptability under the One Workforce initiative. So it also highlights the importance of good employment practices and recognising their impact on population health. So by the end of this financial year, we will have a system-wide framework guiding our collective workforce development. And finally, we received a report on violence and aggression. So this piece, obviously highly emotive, so forgive me if I sort of go off piece a little bit. So it showed that over 20% of BNSSG staff, NHS staff, have experienced harassment, bullying or abuse from patients or the public, with a disproportionate impact on staff racialised as black or brown and those with disabilities. So in response, all providers are implementing support activities which cover trauma-informed care, de-escalation training, risk assessments, visible leadership, anti-racism initiatives and other evidence-based interventions. And so our committee will continue to monitor that into Q4, and there will be a follow-up on the staff survey results in Feb 26. So I know that we all care about this and the scale and our ability to handle violence and aggression towards our staff. And these include racist attacks. So I think the statistic nationally is 200 assaults a day. 14.4% of staff report experiencing physical violence, and that's almost certainly underreported, as we know, because it just is. And yeah, we still lack the answers to some fundamental questions. And I was grappling with this in our last meeting, and forgive me, I'm not very articulate on it, but we still don't have a clear system-wide picture of how repeat offenders are identified and flagged and monitored across our system, across different parts. We don't know what proportion of incidents actually end up as a crime reference number or as a recorded incident or consequence. We don't know quite how we track them. We don't have a full picture on that. And also, there's always the issue that there will be patient confidentiality issues that stop us being able to understand the full picture. So we don't even know that some of these repeat offenders, will it appear on an advanced DBS check? Where do we get this information from? So even framing these sorts of questions, this is difficult, and framing it in a way that we'll get meaningful stuff back that we can actually act on. It cuts across legal, safeguarding, workforce, policing. It's complex, and I get that. But yeah, this is an inter- and intra-system issue. Public sector workers will face this if they're on the front line. So we do have to work out how we phrase this question from now, where we sit as the body that we are, into strategic commissioning. What metrics do we need to have the answers to in order to know that we're actually moving the needle on this? So I guess I'm just setting this out as a badly worded challenge that we need to be able to get some of these answers to know, because I suspect the lack of full reporting is because we've normalised a lot of this stuff. But we, as an ICB, have to set where we think the needle is on acceptability, and then we work from that. Okay, rant over. Thank you. And that's my report.
So that's important. It was an important agenda item at the committee, wasn't it?
Very.
And so the question, I guess, is what do you want board members as a result, in terms of escalation, is it to inform, because actually, as you said, individual organisations are working, but actually there's more to do. So just have a think about a specific ask in terms of escalation. I'll bring Jake in, but just have a think if there's a specific ask for escalation that you want to do, Joanna, for us. But let's finish the comments. I want you to come back in.
Okay, we'll do. Yeah.
Have a think about it.
Yeah.
Jake.
So this echoes some of the conversations that Cathy Ryan and myself have been having between general practice and Bristol. So if a patient is significantly violent in a surgery that they get off-listed, we don't have any formalised process of sharing that information with the out-of-hours provider. And there's a risk there that you could send a clinician out in a car to go to that patient's home, and they go in and something significant happens, or they go to a base and there's something significant happens, and or the ambulance, and or A&E. And we've been talking about how we try and develop a more formalised approaches, and we got slightly caught up in the weeds with sharing data for patients that you don't have a direct relationship with, and DPO saying that you shouldn't be sharing that information. So for me, there's an answer system that I think we have a duty to protect our staff, and we have a duty to share this information, and we should do that as a system, and have a central repository where we share that, but it doesn't exist at the moment.
That's helpful, Jake. Can I bring Rosie in first? That's okay, Jake.
So there was a piece of work which we started between Sirona and ourselves around some of our particularly challenging to look after patients in the community. So each of the bigger providers have what they call a red card process, whereby at a certain point they start to put restrictions around treatment in order to protect the workforce. Particularly challenging for Sirona because they're sending staff into somebody's home, and that can be a really challenging situation. I think that work has paused due to capacity, but I think we should pick it up and make sure primary care is in there, Jake, because clearly what we need is a safe way of treating people within boundaries of protecting our workforce as well as protecting our patients, and be really, really clear on that. So I'm very happy to pick back up with Denise. That was sitting under National Quality Board frameworks under the SQG. So very happy to pick that back up. Sue Monk was leaning in from Sirona, and certainly we were talking to the Bristol group as well, because there is something about a coordinated approach that our client group understand how we're going to look after them and what boundaries that we set for that, but also some really complex stuff about mental capacity acts, DOLs, etc. So very happy to get Denise back onto that, obviously mindful of the stuff we talked about around capacity in our organisations at the moment, but I suggest we tuck it in there, Jake, and I can pull colleagues in from One Care and Bristol to make sure it's a holistic conversation.
It's certainly worth your deputy seeing the paper that went to the People Committee.
Yeah, very much. Yes.
So that would help as well.
Obviously, we can do it from a clinical professional point of view. We will not have the understanding of how to make a joint data set about that, so we would need help with that.
That's a strategic issue, isn't it?
I think Shane wants to come in on this point.
Yeah, I think it's a fascinating conversation with DP about data protection. First rule of Caldecott is we need to share. First rule is we have a duty to share.
Yes.
We have to share it safely, but we have a duty to share, as opposed to, I think our interpretation of data protection is have a duty to protect. So I think it's really important, Rosie, that we get Denise back involved in that piece of work, and the system has a duty here to work with providers, because we have a duty to share to protect the patient and to protect our staff. So that's the first duty of Caldecott, not a duty to hide and not share.
And we can flag on connecting care.
Yeah, absolutely.
And we can all flag on connecting care. So we need to think about what mechanisms do we have already that we could just use better in order to
bring that back.
So, okay, Jake, and then.
So a statement from the ICB, from the board, saying that we have and there is that protection, this is what we would expect as part to do that, is a really powerful thing to go out to individual providers. So if we could have a statement that described that, brought back and signed off by the board, that would be really helpful.
Thank you, Jake. Joe and then Steve.
Yeah, it's been a hot topic in my first 3 weeks, Jake, so thank you for sharing that. But I'm fairly horrified at what our staff are having to go into, and the difficulty that Sirona's had to now in making a decision about withdrawing care. So, you know, we might have a red card in the acute and you might offload your patient, There's no way for the DNs to know when they go in, and some of them are going in on their own. We don't currently provide body-worn cameras, or our alarm system just makes a noise. And this might not be for all of the minutes, but actually, even that, when you're going into an area where, and I don't know Bristol, people have described it's easy to go missing in nooks and crannies. We've spent a lot, and I'm a nurse by background, I'm out of practice, I should just state that, but I totally get the issue around patient safety, but our staff don't feel like anyone cares about them, and our attrition rate for district nursing is high because people don't want to go into those areas. We are currently just looking to take them out of uniform in those areas because I hadn't even clocked that when they see a uniform, there's a risk that people think there's drugs or stuff in the car or equipment, so they're having bricks thrown through their car windows. And we are finding that the conversations we're having about making those difficult decisions are impossible. We will be making those decisions going forward, and on behalf of our staff. What I don't want to do is push the problem to Maria or push it to anywhere else, but we are going to have to make those decisions really clearly, and we will make those decisions, but we're going to need to think about security. And finally, it seems to be prevalent in the diabetic population for us, and I don't know whether you've had that feedback. So obviously there'll be clinical things to understand there, but we do need to do something urgently.
Thank you, Jo. I know you want to come back in on that bit before I bring...
Well, it's just and how we work with our communities. Because I think if our core communities knew the abuse that staff were taking, trying to get someone to treat, we would also get some support from local community groups to help raise awareness of letting people go about doing their business. So I think there's, other stuff we need to do.
And I don't know what we've done on that.
I think it's been a bit transactional, Joe, to be honest. I think we need to regroup. And I think each agency's got stuck in trying to protect its own staff, and actually what we need to do is say, these are our citizens, this is our workforce, how do we... We've
got two risks.
Yeah, and how do we have a really good escalation process that's multi-agency, where we group around an individual and work out how we're going to look after them, or if we can or we can't look after them, and make a joint decision.
Yeah, quickly.
Okay, thank you, Rosie. Steve?
Yeah, Rosie said it, it's about how we join up, because social work will have the same sets of issues. The ambulance service will have the same set of issues. If we can't share information, we're stuck. And my argument would be the same as Shane's. We have a duty to share appropriately and protect. So, and sometimes the data protection advisors don't quite get that bit.
Well, it's risk averseness, isn't it? That's the thing.
So I do think, escalating it up and then saying no, this is our position would be helpful, and we can take advice if we need to take advice. But my concern is that if we knowingly are sending people into risky situations, there is a liability that sits on the employer.
Absolutely.
So we just need to be clear where that could go.
Jeff and then Dominic. Thank you.
Are we sure nobody has looked at this somewhere else nationally?
I think they might have done, Jeff.
I'm quite staggered we're having this conversation. And coming from a policing background, in 1980, we had, on the Police National Computer, you would have had warning markers that said that were suicidal, drugs, and so everybody would have had all that information.
Yeah.
I think if we're having this conversation, I think Rossie's right, this needs to be multi-agency. You need the police involved in this, we need the ambulance involved in it, fire, because it's a blue light response as well as, that's emergency, but what about community? I'm
staggered by it.
I'm staggered we're allowing our staff to go in somewhere without giving them the information about the person they're going to go and see. And I know we do it in pockets like the GP programme, where if someone kicks off in your practice, we'll red card them and then we'll have a surgery where the police will attend. But I can't believe that somebody else around the country in 2025 has not said, we need to have a look at this. If they haven't, unbelievable, isn't it? But this would be a brilliant piece of work, and I think I would agree with Shane. We could even involve the Information Commission on this, but we start from a principle of protect
our people, absolutely.
And then if they think there's a data protection issue there, then we'll deal with that as we get to it. But our staff have to be the priority.
Thank you, Jeff. Let Dominic come in.
So this speaks to that. So we have a security management specialist who liaises with the police. I suspect Maria will have at least one. I don't know if Serona do. Others may not. But if we bring those experts together with the police, I think they would probably tell us a lot that we don't know in this conversation. I think there probably is quite a lot already happening. They may well have some asks and some recommendations.
So, Jaya, that was a good. That was
Bloody
really
good. Can I say that? I can say that. We're not on TV. We're good.
Yeah.
Right. Sorry. I'm tearing up a little bit because this is the conversation I really wanted us to have. So you said, what's the ask? And actually some of it's already been covered. So I want to know, and I want to know where the figures go to in terms of how many repeat offenders are identified, how they're flagged, where they come up, whether or not actions are happening. We need a set of metrics that work for us all so that we can protect our people. As you say, Jeff, we need to get police and anyone else who's on the front line, public sector, public services working, so that we can join the dots on all of this. Because if there were warning markers before on people to protect others on the beat, then we can do this here as well. I know the laws have changed significantly, but we can still do that. I would like it to appear in an advanced DBS check at the very least, so that it has an effect on employment too. They think about it as an impact. Their behaviours must have a consequence. So anyway, that's my general ask. That I am very, very pleased. And if there are action points relating to what we've just discussed, that would be my ask.
And I think there are.
I think there's a sense of urgency on it as well. In that, what if someone working for Serona went into somebody's house tonight and was raped or murdered, or
can I just say, we have had an incident in the last 2 weeks. It's not acceptable. It's a level of risk we can't carry on doing.
So I think, Rosie, the specific action is sitting with Denise to regroup.
It'll sit in my division and we can pull it through, but obviously what we need to lean into is the colleagues in provider settings, because we don't have a security management specialist. So I'm very happy to do the bringing people together, to agree a system approach, but I'll need partners to lead in.
Yeah, and I think there's an appetite here for that and an expectation. Jo, did you have your hand up?
Yes.
And then Richard, do you have your hand up too?
Yeah, very
After
briefly.
Jo,
It was just something to think about, and if we are going to do that work and we're going to prioritise that work, which absolutely, how we communicate that to staff, that piece of work is going on, not waiting to the end, that piece of work is concluded, because I think that will make a massive, massive difference, because this has come through the staff lens, that's how we've grasped it, but it's much bigger issue.
Yeah, absolutely right.
And then how it translates through to the other side of the transition, because we can start this now, but they need the promises that we've made. We must keep into the new transition.
It's another example of something that can't be lost.
Yeah, absolutely.
Yeah. Richard.
I'll take the other lessons to learn from other systems that we can bring back.
Thank you, Richard. That's great.
And just from experience, staff associations are to enable a lot of this, because they will cut across all our organisations, and they will not believe, well, they will believe it, but there'll be a good sort of where should we be starting with some of this, because we could be in danger of over-complexing it, but actually, I agree with Jo, let's get the quick wins of this one.
Jaya, thank you. Was there anything else from...
No, that will be my Christmas present.
Thank you, Jaya. Jo, was there anything you wanted to pick up for open session around people?
No, I think that's covered. That's covered. That paper will be attached to the minutes, so the board will see that the paper that's driven this conversation. And that's obviously written from the staff perspective, and we're taking it as we should do to a much more strategic, transformational level, which is fabulous. So thank you.
Great, thank you. Thank you very much. Steve, Finance, Estates and Digital Committee.
Thank you. Chair, I'll take the papers as read. There's a couple of bits that I just want to flag, and then Matt might want to come in as well. As colleagues will know, the ICB has a duty to break even, as do the provider organisations as well. The ICB's finances at the moment are signalling that we are on the trajectory to break even, so that's positive. However, there are risks within that we're mitigating, so that's very clear. In terms of the risks that we're looking at in terms of the system, at the moment we're projecting a 10.3 million risk that we're trying to mitigate and manage down. Some of that is within our control, some of that is difficult because it's related to the impact of strikes and also the impact of transition. So that could go very wrong, if I'm honest, in terms of what that has in terms of an impact. We are tracking this very closely, and the system DOFs are working together across the system to make sure that we've got sight of what's going on. But we are going to be asking for a deep dive from UHBW to understand better what's going on there and whether there's anything else that we need to do. And that'll be January, I think, Maria, just so, and I think that's been signalled back to UHBW. I don't underestimate the pressures that everybody's under in terms of getting the finances right. Clearly, what we want to try and do is to land this so that we do break even, because the impact going forward, if we don't, is significant. So we're trying to land this in a way that allows us access to the good behaviour funding that might come as a result. The other thing that we're working on, of course, is then the forward plans. And there are obviously, first pass of those, there are significant pressures within that, and we'll be managing that, working with Region to make sure that you're aware of what's coming. And we're obviously keeping an eye on the Gloucestershire side of the equation as well, to make sure that Gloucestershire and BNSSG are working together to create those final plans, recognising we're independent until April. But also that we're both working on trying to land the break-even positions, because both sides, both of us need to make sure that we do that to then be able to access the additional funds afterwards. So that's it in a nutshell. That's where we are. We're managing it. There's some good work that's been done on the IT side, mitigating some of the risks that we would have been carrying forward in terms of how do we make sure that we're passing some of our activity into the acute providers, and that's gone really, really well. And I think we've done some good work in that space, so I'm confident in there. And on the estate side, there isn't much happening as far as I can see at the moment that's coming back to finance and estates digital.
Brilliant. Thank you, Steve. Matt, did you want to add anything before we open it up to comments or questions?
I think Steve's largely covered it. Just to specify, if we do achieve as a system break even this year, then there's 13 million revenue and 13 million capital to have access to next year. So there is a very real reason for it to break even. That being said, I think we are worried but not panicked by the gap. So just trying to pitch that right to say that there is a gap. It will take an awful lot of combined effort, and all organisations are working well to do that. But I don't want to gloss over and say it's 10 million, it'll be fine. We expect it will be fine, but it will take an awful lot of effort to get there. And similarly with the plan, we have a draft submission in a few days' time, on the 17th of December. We're expecting a system for that to be approximately 48 million deficit. We have discussed that with Region. They did not fall off the chair. So the expectation is that by the final plan that will be zero. They are testing that with other systems. I know some local systems are much bigger numbers, but again, it is of concern, and we have already set a 5% efficiency in achieving that. So we are really working hard to understand what opportunities there are. I think there is some work around the opening position. We need to make sure we factor in the recovery plans that are happening this year and making sure that is flowing through. And I know that I've spoken to Neil about that, and he's working on that. So just to give people that kind of context of how tight that sort of financial position is going into next year as well. Just to make everyone a little bit concerned, but not panicked.
Okay, thank you.
This is Captain Mannering type approach. There is an important point here, is that every year for the last 3 years in our existence, we run hard to keep the finances in check, and the savings required are not insignificant. Yet in all of our conversations we talk about needing to prioritise and needing to shift funding into areas of more need. Our headroom to be able to do that it's really hard, because we're always running to keep up with the here and now. So there is something about how do you break out of this? How do we break out of this? How does a system break out of this when we're always fighting to keep on the tracks, basically? And I'm not sure I've got an answer, because we keep being, you know, there are some things that we know and we can manage. There are some things that come along, and some of the unexpecteds are things like the cost of the diagnosis ADHD ran away, and we have to deal with that, and there are other things that run away and we have to deal with. So it's just a marker that at some point, if we want to prioritise differently and if we want to move money, we're going to have to make some hard decisions, and I guess that is going to be the function of the new ICB.
Dominic.
Mine is, I suppose, a philosophical question, therefore not necessarily for answering now, but it would be good as we approach the new regime, as it were, to get a formulation on this. My understanding is that in the new world, the post end of the financial year world, providers will be held to account directly by NHS England. The budgets will not be consolidated into the ICB into a single control tower.
Yep.
And therefore the risk that Steve just described becomes a greater risk. And added to which there may not be transparency in real time through, now we can mitigate some of that through having combined meetings and things, but I think we need to have a very clear formulation as an ICB as to how we're going to do that well.
Thank you, Dominic. Maria, sorry.
I totally agree with Steve. You know, you can't fix the plane while flying the plane. As we try to do our in-year, and you know, we're very keen to submit a compliant plan, but recognising, you know, 5% historically has not been achieved, certainly not in your traditional recurrent savings way, and therefore gets harder every year with what we have to carry over. I don't know whether the promised world of multi-year contracts and allocations will allow us to do something. I mean, it's been talked about, but we don't seem to have a mechanism quite yet as to how that will work. Whether IHO on multi-year outcomes contracts allows some better flexibility, but I certainly don't think we can carry on with 5% on a yearly basis. We just can't. I think, you know, Shane, you mentioned the other day, this requires big ticket change now, big ticket initiatives where we do things that can't just run down at the end of one year and start the first day of the next tax year. So, you know, either between us, and that includes some of the capital as well, to put money in on the current capital allocation basis to try and do new things or move the state round or acquire resources to do things differently, we are really restricted. So I don't have the answers, but there is stuff in the 10-year plan which alludes to it as being a problem that does need fixing. So let's hope there is something coming.
Thank you, Maria. Jane?
Yeah, and I think, Maria and Dominic, your point about the individual organisation again, we have to be really strong as a collective. So it might not be as a system as is known now, but as a collective, because if we go back into individual organisation, individual accountability, we'll never make those big bets. Because actually, the big bet over here might have an outcome over here, but if those two are different organisations, well, I'm sorry, I'm being measured on this. So that's what the new system is, as opposed to strategic commissioning, and I couldn't agree more. We have to hold that. That doesn't mean that someone else has the accountability for your financial break-even, but you won't be able to financially break even if we don't think of this as a system, and therefore I think we need an agreement, and I think we have that agreement. We continue to work as a system, even if the architecture of a shared control total doesn't exist. We have to work as a system, because the big bets won't work. You know, how are we ever going to shift outpatient transformation into something completely different if we just think about organisation?
Then we have to resource to make sure that it is, because otherwise it will, other priorities will take place. Right?
So any other comments or questions for either Steve or Matt? Richard?
Can I just comment very briefly, Alison? NHSE is part of that model you've described, Stephen, and maybe a major influence part. in the model region blueprint, it talks about a role of strategic leadership. And I don't think people know what that is yet, but there's an opportunity for that to be about a better set of relationships that spend time talking about this. And I think the opportunity is there for the ICBs, the chairs and chief execs, to be asking questions of the region about how we're creating that, to be able to create the space that has some of this conversation. That can sit alongside performance management, that's still going to be there. But I think there's a real opportunity to carve out a bit of space, a bit of quality time for that conversation. Forgive my optimism, but I hold on to it.
Good.
Yeah.
I think you're right.
Yeah, keep going with the optimism. Steve, thank you very much, and Matt. Item 10, Primary Care Committee. We've got the minutes of the 23rd of September meeting, which I reported verbally to the board last time. Key messages from the committee meeting on the 25th of November. As usual, risk-based approach, risk register up front and central. Just three things to pull out, nothing to escalate to board. The medium-term plan, which we've already talked about, we had the focus on primary care in its widest sense. As with previous years, there's uncertainty around contracts and what they might look like. I don't think that's a new thing, but we were assured as a committee that the work that the team are doing is really good in terms of the first submission in December and the final submission in March. They've had a planning day. Just in terms of our current performance around in the operating plan, around the 4 key objectives of primary care, which are all designed to help the system as well as individuals. GP appointments exceeding the target, units of dental activity, which is important for board members, exceeding the targets. Pharmacy first, which I'll talk about in a minute, also exceeding what it was expected to do. The one area which is under plan is the urgent dental activity, which is a known issue, it's a risk and is still being worked, but it's getting better, which is good, but still under plan at the last committee meeting. We had a deep dive into Pharmacy First, and I know that I've talked about this before, but the Pharmacy First is one of the 4 key deliverables, and the performance across the NSSG is nationally #1 in terms of pharmacies being able to take a view of 7 additional conditions and care for people in the right place. So we are the highest performing ICB in the country. 91% so far of surgeries have referred patients. The Q2 average, 11,200 referrals, and 1,900 from the urgent care system. These are all people who have been referred to a different place to receive their care. 80% of the referrals are completed by Pharmacy First, so they haven't gone on to somebody else. They've dealt with the issue, whether it's advice with medications or a huge number of referrals from GPs over the last 12 months. The report says over 100,000, so we just need to understand that feels high, but if that's just people who are hopefully being seen and signposted to the right place, which then takes pressure off other parts of the system. So it was important to have that deep dive and to see the good work that was going on and the really good leadership across the system on all aspects, and the good working with the local pharmacy committee. The third area, just to alert the board, is starting to really understand quality and safety in pharmacy, optometry and dental services, which were delegated previously. There is a community pharmacy assurance framework in place, which is really good. It helps us to understand that's been completed for our patch. Just to note, it's a work in progress for us at the moment to understand the quality and safety and improvements in optometry and dentistry. So it is a work in progress. There is a primary care highlight report here, which I think is really helpful for the board to see some of the metrics. Dave, was there anything you wanted to pull out that I didn't?
Not that you haven't already, Alison, actually.
Oh no, I'm stolen your thunder.
I mean, a couple of others just while we're here. Then you've seen in the press that Secretary of State is ongoing discussion with the BMA around the GP contract, but the key issue nationally is around online consultations, and I wanted to say locally our practices have worked so hard to embed this within practice. So my report here says we have 99% of practices now with online consultations, but I can't think which 1% that isn't. There must be a branch that isn't, but all of our practices work really hard to embed that, so I think that's great. And I was also going to note, Alison, that finally we're turning the corner on improving and increasing access to dentistry, both in terms of UDAs, but now also urgent care. And we've debated this at length at this board over the years, but finally to turn that corner and seeing access improvement is really good.
Mm. Thank you, Dave. Any comments or questions on primary care? Kevin?
Just briefly, so over the last quarter we've had about 301, we've had exactly 301 pieces of feedback through Health Watch around primary care and pharmacies. And to keep in the theme of good news, 129 of those are positive feedback about people's experience. And we released a report in June this year around people's experience of Pharmacy First, and 60% of respondents to that said that they would recommend that programme to friends and family. So I'll share those across. It seems like there's some good news stories there.
Yeah, thank you, Kevin. That's helpful. I'm sort of almost interested what the other 40% and what the other percentage are also saying. So could you feed that back too?
Yeah, I've got the reports.
Yeah, great. Thank you. Jaya?
Just to understand if, because a lot of pressure now is falling on pharmacy because of Pharmacy First, are we aware of any pressures that are sort of emerging that we need to sort of provide support on or look forward on?
Well, the pressure, Jaya, is more around the standard contract for community pharmacy.
Mm-hmm.
Pharmacy First is where practices are, or pharmacies are able to kind of push the kind of their business model and create some additional revenue for the pharmacy.
The footfall, yeah.
The issues that we've seen with Jehoots recently and the kind of general route standard community pharmacy contract are what put the services under pressure.
Okay.
And that is, we are at a similar level of negotiation with community pharmacies as a general practice about the future model moving forward. So it's not community first, pharmacy first is a good thing for pharmacies. It's this general contract where the challenge is.
Okay, thank you.
Jake, did you want to come in?
Yeah, just to echo that really, Richard Brown came from the GPCB. He's very clear that the Pharmacy First brings extra income and is supportive. And they have threshold targets that if they see over a certain number each month, that they get extra payment, £1,000 a month, and it's really supportive. So, and practices are really well for it. It's only it's 4 or 5 patients per day per practice. So the 100,000 is a lot, but we've got a lot of patients. And we're seeing many millions over the year, but it all helps.
It does, yeah. Thank you. Jo?
I was just going to ask, but I think Jake's answered it. Where you triangulate the impact of it? Is it at the front door of primary care, front door of urgent care, front door of emergency care? Is it predominantly, is it a bit of everything? Can you see it?
It's probably primary general practice that sees the most benefit, I think, from that. Again, small numbers, but it all helps.
Yeah, yeah.
And, can you say something? Lost it.
Sorry.
Oh, no. Yeah, can't remember. If I remember, it'll be inappropriate, but I'll bring in someone else. Okay, that's. Oh yes, no, I've remembered. The key question, I think, Jaya, which committees has been asking, is around how can we support resilience in pharmacy, optometry, and dentistry. There's an established programme in general practice which we've got good assurance works when practices take the offer.
Yes.
The same can't quite be said. I know the team have been working on it, but clearly, we're on a time of change. But that still remains a key question. Is there anything we can do around resilience for the pharmacy, optometry, dentistry? They need to be at the same level as primary care. They're all 4, table legs. They're all the same. They're all the same importance. So I think that is something that's still on the table in terms of being able to support.
Thank you.
Because it is the key question.
Yes.
And we've seen a lot of pharmacies helping out when Jehoots were in issues, and neighbouring pharmacies, which has been great. It has put additional strain on them as well. So, but yeah, resilience is the key question, I think, when you're looking at primary care services. Great, okay, we've done, so on item 11, Strategic Health Inequalities Prevention and Population Health Committee, Jeff.
Yeah, thanks Alison. We last met on the 7th of October and you've had the minutes of that circulated. You saw that what was escalated to the board today around the cardiovascular disease in the African Caribbean community, and similarly at some stage the board listening to an input around healthy weight, smoke-free BNSSG and the response to alcohol and drugs. I think would be similarly impacted. But the committee needs to do the work on that. They are quite well progressed, and we decided we were just going to look at sort of 3 or 4 key areas when we established the committee, and I think it's had a resounding success. So you will see more of that to come through. We've got another meeting now on Tuesday, and I'll update to the committee then, but I don't think there's anything else at this stage that we probably need to update on, Alison.
Right, any questions or comments for Jeff? Okay. We'll just carry on with the meeting. We're going to get to the point of questions from members of the public at the end of the meeting. I couldn't quite hear, but I thought that's what you might be saying. Yeah, so if you so in terms of, we've received item 12, item 13, Dave, Southwest Joint Specialised Services Committee, you or Shane?
So I attended the last meeting, Alison. I can't think of anything of escalation to the board. A conversation around how specialised services embed within local planning discussions and an update on the PICU network, but nothing to escalate further.
Okay, thank you, Dave. And Jeff, the Integrated Care Partnership update.
Yeah, thanks, Alison. I think the minutes have been circulated from the 28th of November 24. So there has been meetings since then. But I think we probably that came from. I think we've probably circulated the wrong minutes. We've got a meeting coming up in a couple of weeks' time. The last meeting of the Integrated Care Partnership was a seminar session, really, which you've heard today about neighbourhoods and what that looked like. And that was there's probably 3 or 4 people who were there at that conversation, and it was really helpful. Loads came out. And what I mentioned earlier on in the conversation was that there's a real keenness for the Health and Wellbeing Board chairs who are all on the ICP to come together as a collective and not lose those conversations we're having in the Integrated Care Partnership, because it is a different conversation to hear. For those of you who are part of that, it's a broader conversation. We are a bit more focused. We are a lot more focused here in the ICB on the business, which you'd expect us to be as a constituted board. Whereas the ICP has a broader conversation, it's a different conversation, but I think it's worthwhile, and we will lose that if ICPs don't exist in the new structure. So I think there's a keenness to make sure that continues. And I'll update you after the next ICP meeting, but I don't think there's anything else at this stage, Alison.
Great, thank you, Jeff. Any questions for Jeff? ICP, no? Okay, great, thank you. In terms of questions from members of the public, we have got members of the public here. We have received one written question, but I'll just ask other members of the public who've been here, is there anything you want to ask? No? Okay. So, I think I can see. Hi, Barbara.
Can I go to the mic?
Yes. Yeah. Are you going to read your letter out?
No, not really.
Right.
Well, first of all, I came here in the spring and I received an assurance from Dr. Farrar that the Frenchy project would go ahead. So you can imagine, because I asked Sarah Truelove to keep me informed, and then I gathered that she'd gone to Gloucester. So she had agreed she'd keep me in the loop, so of course I wasn't kept in the loop. So, you, David, sent me a letter and you said that you are not, in other words, the French aid project has been stalled. I was on a public involvement in 2004. I was 61 then. 21 years go by. I'm 82 now, and I'm still pursuing this because we have an incomplete reconfiguration of services. I would argue that we are in a very difficult position because we have massive building projects going on all over the place. We've lost Emerson's Green GP surgery. That's had to amalgamate. And so all we ever experience is loss. We don't get any increase. But I'm furious that this is about the 5th hiccup Well, it's not even a hiccup, it's a halt, with no prospect of anything happening in the future. Maria Kane and that hospital is handicapped by a parasitical PFI that's been dumped on us and sucks the lifeblood out of our hospital. If they did make profit, we have to give it to venture capitalists. This is simply not good enough. We are a special case, and I don't know why you're not all up in arms. I can count about 5 false starts, and I'm sure you can, David. By means of Grok AI, we've established that anything between 22% and 33% of the beds in Southmead are occupied by bed blockers. They've got nowhere to go. It's not their fault. There is this movement to put care into the community. Well, can I just tell you what that means for elderly people? Many of whom haven't got any relatives, they're incapacitated. It means that the elderly are looking after the elderly. And I'm one of them. I'm absolutely furious. And it's not easy. It's not easy doing all that. We're like social workers because we're having to care for ourselves. And I hear so much about, oh, deprived areas, and undoubtedly we've got more deprived areas than we want to admit. But being elderly is also a deprivation. You can't just rely on your neighbours. Often they don't want to know if they're younger, they're busy, they've got to keep their income up, and they're not always available to get you to surgeries, to get you to treatments. I'm so angry about this. I think it's high time we invited West Streeting, instead of going around hospitals with his sleeves rolled up, he needs to come here and see we have a very particular problem, an expanding number of and nothing, South Gloucestershire, we can never have anything. Why not? We pay our rates like everybody else, we pay our taxes, but we're never, oh no, we're never in the running. Part of me thinks that some of this is about duffing about for so long, and then you'll say, oh no, the site's not big enough for what we need. We need community provision now. We need rehabilitation beds that we've needed since 2010. We had 2 years of work on a community facility, got to 2010, in came the Conservatives, stopped it. All the work was done, perfectly good plan. So you invite people, oh yes, the public, and then they come and they give their time, they give their effort, and it gets nowhere. So why not invite West Streeting or Sir Jim Mackey, or both, to come down here, not for a fancy lunch, but to drive them round those developments, round and round. That'll take half a day. Eventually, we've had Emerson's Green, we've had Lyde Green. Lyde Green's going to end up in Kendallshire. And all these people arrive, and we've got nothing. You referred to a critical incident. Well, there have been a few. But it never seems to impact upon provision. So I'm saying to you, instead of sitting here rearranging the decks or the chairs on the Titanic, do something useful. Do something whereby you get power down here to show them that that PFI is it's disabled us. So we have to rely on the BRI to sort us out. No good relying on our MPs. Mine is busy arranging coffee mornings. They show no interest whatsoever. So it's up to you all to issue an invitation to those two. How about it? Put your money where your mouth is and call them in and say, we've got a problem. Thank you.
Thank you, Barbara. For the record, I want to note that you have sent us in a letter. We will make sure there's a formal response to that letter, and it will be in the minutes because that was the letter. Is there anything, Shane or Jeff, that you wanted to say at this point to Barbara?
I think I would like to formally in the letter address your comments about PFI, care in the community, elderly deprivation, because I would have a different view, and therefore I would more than happily share a slightly different view, and then we could have a discussion about that. Not necessarily
Well, put it in, yes.
I would have a slightly different view, but I would happily do that formally, and then we could meet to discuss that.
Can I just quickly say on staff safety, because yes, I do appreciate it's a problem, but if you can see where Vizu taxes are on your phone, are you able to see where your staff are working at any given point? Secondly, rape alarms, I know they're cheap and cheerful, but also, I mean, the police have a means of communication if they're put into difficulties. But I think, yes, I mean, it would be wonderful if people were appreciative of the staff and kept their tempers, unlike me today. But you can't rely on that because people are ill and desperate. Thank you.
Yeah, but before you go, can I just say thank you for coming in. I know how passionate you are about this, and I know you feel strongly, and the points you make are really well made. We do have to make choices as a board, and you did what I talked about today about making sure we get the evidence base for that. We haven't got enough money to do everything for everybody. We all know that. But we are not ignoring what you're saying, and I promise you that I will have the conversation with Shane about how we make sure we're conversing with you and we're writing to you and updating you. We can't promise you everything, we can't. And you know, we have an investment in South Gloucester this year, but we're in an unenviable position that we have not got a bottomless pot of money. We never will. I think the invites to Jim Mackey and West Street Inn would see a lot of good things that are happening here, and that might not be the answer for us. But I'm just grateful for you turning up as always, and I'm more than we are not ignoring what you're saying.
My elderly neighbour was discharged after being after getting better from the hospital with a chest infection. Discharged at the age of 86 to the care of his elderly wife, who's 87, discharged with COVID, and he couldn't climb the stairs. So they've had to get a stair lift in, etc. But the point is, his elderly wife has got an ulcer on her foot. So at 87, she is coping for her husband, looking after him, and she can't get a domiciliary Sirona chiropodist to visit unless she's in bed. She'd love to go to bed. She can't. She's housebound. But you have to fight a case all the time. It's just beyond the joke. Thank you.
Thank you, Barbara.
Right, colleagues, that brings us to the end of our board meeting. Thank you very much for your time today. I think we've gone through a really important subject, as we always do. Though, as I say, there isn't a meeting in January. This is the point to wish everybody a good festive season. And we will next meet as an open board on the 5th of March 2026. Thanks very much.
Thank you, Alison.